Bore da I bob un ohonoch chi efo'r yma, a chroeso cynnes iawn I gyfarfod heddiw o'n bwrdd ni, sef bwrdd iechyd addysgu Powys. Ac fel y gwelwch chi, dyn ni'n cynnal y cyfarfod y bore yma yn rhythwyr, ac mae'r cyfarfod yn cael ei ffrydio'n fyw ar ein gwefannu. Ac yn ôl ein harfer, mi fydd na recordiad o'r cyfarfod ar gael i'w weld ar-lein ar ôl y digwyddiad heddiw. Yn enw I ydy Carl Cooper a fi ydy cadeirydd y bwrdd. Ac ar y sgrin yn y man, fe welwch chi manylion am ynghydweithwyr ar y bwrdd, sef yr aelodau annibynnol yn ogystal â'r aelodau gweithredol. Ac hefyd, y mynychwyr ychwanegol fydd yn bresennol yn ein cyfarfod ac fydd yn cyfrannu at wahanol eitemau ar ein hagenda y bore yma. Jyst gair o esboniad I gychwyn, ni, y bwrdd, ydy corff llywodraethol y bwrdd iechyd. Ac dyn ni yn cynnwys, fel dwi eisoes wedi crybwyll, aelodau annibynnol ac aelodau gweithredol. Ac efo'n gilydd, dyn ni yn ffurfio bwrdd unedol. Ac ein pwrpas ni ydy sydd yn gyfrifol am 4 peth yn benodol. Peth cyntaf ydy pennu cyfeiriad strategol ar gyfer ein sefydliad ni. Yr ail beth ydy pennu archwaith risg wrth gyflawni ein hamcanion strategol. Yn drydydd, dyn ni yma I fonitro cyflawniad a pherfformiad yn erbyn yr amcanion strategol hynny. Ac yn olaf, ac yn sicr nid y lleiaf, os rhywbeth falle y peth mwyaf pwysig, ydy gosod naws a diwylliant, a modelu y diwylliant hwnnw fel bwrdd dros ac o fewn y sefydliad. It's a great pleasure this morning to be able to welcome each and every one of you to this meeting of the board of Powys Teaching Health Board. As you can see, we are holding this meeting virtually, and it is also being live streamed from our website. And as always, a recording of this meeting will be available to watch after our meeting today. My name is Carl Cooper, and I'm the chair of Powys Teaching Health Board. And on the screen, in a few moments, you will see details of my board colleagues, both independent members and executive members, those that are present today, and also some additional attendees that will be with us today to contribute information and so on for various agenda items. As a board, we are the governing body of Powys Teaching Health Board. As I've said, we are comprised of independent members and of executive members, and we form a unitary board. And our responsibility has 4 main elements or aspects to it. The first is that we are here to set the strategic direction for the organisation. Second, we're here to set the risk appetite in the delivery of those strategic aims. Thirdly, we importantly monitor delivery and performance against those strategic aims. And fourthly, and certainly not least, arguably most importantly, we are here to set and to model the tone and the culture of our organisation, ensuring that how we do things is as important, perhaps more important, than what we do. And so please note that during our meeting, you may see that I and others don't always look directly into our camera. And that's simply because we are working off multiple screens, and occasionally we will need to turn to our right or to our left to look at different screens to access information and papers. And so Hefyd, yn ystod ein cyfarfod y bore yma, mi fyddwn ni yn cymryd egwyliau ac pan dyn ni yn cynnal egwyl, mi fyddai'n esbonio hynny ac mi fydd na wybodaeth ar y sgrin dim ond i esbonio beth sydd yn mynd ymlaen. Mae'r bwrdd dyn ni'n cyfarfod heddiw yn gyhoeddus yn unol â rheoliadau y Gwasanaeth Iechyd yng Nghymru. Mae'n bwysig, dwi'n meddwl, i esbonio taw nid cyfarfod cyhoeddus ydy hwn, felly dyn ni ddim yn gwahodd cyfraniadau uniongyrchol gen aelodau'r cyhoedd, dim ond aelodau'r bwrdd a'r mynychwyr ychwanegol fydd yn cymryd rhan yn ein cyfarfod heddiw. Serch hynny, dyn ni yn croesawu cwestiynau ac adborth gan y cyhoedd trwy amrywiol ddulliau, gan gynnwys trwy anfon eich cwestiynau yn uniongyrchol ato ni. Ac os hoffech chi gwneud hynny, fe welwch chi ar ein gwefan ragor o wybodaeth ar sut i gyflwyno eich cwestiynau. So during our meeting today, we will be having breaks because we have quite a packed agenda and quite a long meeting today. And when we have a break, there will be information on the screen simply to explain to those that are watching that a break is taking place. As a board, we meet in public in line with NHS Wales regulations. It's perhaps important to explain that although we meet in public, this isn't a public meeting. So there aren't any direct contributions or there isn't a direct participation from members of the public. That said, questions and feedback from the public are very welcome by us as a board in our meetings, and members of the public can always send in questions for our consideration in these public meetings. And if you'd like to do that, there is more information on our website as to how to submit your questions. Board colleagues will be aware that during November, our organisation was placed into level 4 targeted intervention, a higher level of escalation by Welsh Government and for the domain of finance, strategy and planning. That escalation status is a result of being in financial deficit, and that's due to ongoing system demand and workforce pressures. And what it means essentially is that we're unable to deliver a financially balanced position, and we have an in-year deficit plan of some £15 million. Now, this position continues to be of significant concern to us as a board as we balance the delivery of our plans and our statutory responsibilities for providing high quality healthcare for our population with the reality of rising costs and operational challenges across our estate and across our suite of services. Fel mae cydweithwyr yn gwybod, ddaru ni cynnal cyfarfod y bwrdd ychwanegol ar y 10fed o Ionawr, ac yn y cyfarfod hwnnw, ddaru ni canolbwyntio yn benodol ar rai ystyriaethau yn ystod y flwyddyn i leihau ein diffyg ariannol. Yn enwedig, comisiynu gweithgarwch dewisol gyda'n darparwyr gwasanaeth iechyd yn Lloegr. Gofynnodd y bwrdd yn benodol i rywfaint o waith pellach gael ei wneud, ac mi fyddwn ni yn treulio peth amser yn ystod y cyfarfod heddiw yn trafod hynny. We're all aware that the board held an additional meeting on the 10th of January where we focused specifically, exclusively on some in-year considerations to reduce our deficit. Notably, the commissioning of elective activity with our NHS England providers. And the outcome of that meeting was that we didn't take a decision on that day regarding those matters. We asked for further work to be undertaken, and we will be spending some time during our meeting today to discuss that update and to take that forward further. And so now, without any further ado, we move to our agenda today, and the agenda and all the papers for today are available publicly from our website, and so please do access those so that you can follow not just the agenda, but the information that is available to us today for this agenda. And I turn immediately to item 1.2 on our agenda and declarations of interest. Our register of declarations of interest has been made available for reference, but I will invite colleagues to declare any declarations of interest in relation to any agenda item that doesn't appear on that register. Does anybody want to make a declaration? No? So thank you for that. We turn to item 1.3, the board action log, and most of the actions on the log are completed. There is one action, PTHB 24131, that is on track and that is being referred to our Patient Experience and Quality Committee for consideration at its February meeting, which will also come back to our board meeting in March, and that's to do with the People's Experience Framework. So I don't think there is any additional discussion that needs to be had today on any of those actions, but I will just pause briefly so that anyone can come in if you think otherwise. No, so thank you for that. Are there any other matters arising? Also, we'll come to that later when we deal with the minutes. So we go then to item 1.4 and to our experience story. And our experience story today is different to previous ones, and it deals with an experience of grief and bereavement. Which is very moving and which connects with the experience of all of us in reality. But I will ask Claire Roche, our Executive Director of Nursing Quality, Women and Family Health, to come in and to introduce this story to us. Thank you, Claire.
Diolch, Chair. Bore da pawb. Good morning, everybody. I am very pleased today to be able to share with you a story that was captured as part of Bereavement Week. And we have a really brave member of our Powys Teaching Health Board team, Elaine, who shares her very personal story. This is a story of love, loss and bereavement. And Elaine has been extremely generous in her time to provide this story as part of Grief Awareness Week, and has been really kind to give us permission as a board today to both hear and reflect on her personal story. Thank you.
Myself and Stan have been together for 27 years, engaged probably for about 20 of them, but never got around to doing anything about that. Too busy with life. We've got a daughter, Chloe, who's 11. Just normal, happy family. You know, we had a good life, did a lot of travelling when we were younger, and you know, he's been my whole life since I was 19. I think it was March time. He was feeling a bit run down, nothing specific. He had a bit of a chest infection. GP did some routine bloods, and they found that his sodium level was dangerously low. Thought at the time that it could have been all down to infection, so he got admitted to Neville Hall. But they did all the routine things. His chest X-ray showed something on his lung. CT scans and MRI scans later, he was diagnosed with stage 4 lung cancer that had already spread to his spine. came out of the blue. Obviously we were gutted, you know, but we'd always faced everything together all our life. So, you know, this was going to be no different. And we just faced it head on. Before we could even see the oncologist, the tumour in his spine caused compression. So he was rushed down to Blindra as an emergency. Had some radiotherapy, but it was too late by that time. He was paralysed from the waist down. Sam didn't want to know how long he had. That was something he knew. We knew it was terminal, but he didn't want no specifics. I spoke to the consultant in Belindra, and he had said weeks, months possibly, but unlikely. I think Stan knew. I think he did know. His wish then was to, and his goal was to come home, stay home. He didn't want to go back into any hospital, and just, you know, and live, try and enjoy what he had with his family. Chemo wasn't an option at that point. It was too far gone. He said that the chemo would probably do more harm than good. I found that quite hard because we'd always faced things together, but this was kind of the first thing that I knew myself, and that kind of a realisation that I was going to lose him at some point. And that did hit quite hard at the time. So he came home from, but we got him home from Belindra. The community occupational therapist visited the day we came home. And Mia, and she was absolutely wonderful. We had all the equipment was ordered. The only thing that we would have had to have waited for was a specialist wheelchair because of where he was paralysed. So we hired one of them while we were waiting for the NHS one. Within 2 days of being home, he was, you know, we had a hoist there. He didn't have a hospital bed. He refused to have a hospital bed. That was just wanted to carry on as normal. Within 2 days, he was hoisted out into the chair, and he was out and about in his wheelchair, and able to do some of the things. We wanted to make more memories, but obviously with him confined to that chair was difficult. But we did what we could. Telling Chloe was, and explaining to her what was going on was hard. That was very hard. She's lost her grandfather and her uncle within the last couple of years as well. So it's kind of, that was one thing that Stan was really gutted about. That, you know, and one thing he said was that he wouldn't be around to do his job as a father, which was, that we had so much support at home. District nurses, Macmillan, and you know, the OT was on hand if there was anything that we needed. So without them, we probably wouldn't have carried out that wish of his to be at home. I wasn't in work at the time, obviously, because my full-time job then I was looking after him, which was the priority. So life was difficult at that point. We got married on 20th of May. We did that at home. Not the way we would always planned it. So that was a magical day. Chloe was bridesmaid, so we tried to make the most of, you know, what we could. And then he died 12 days later, 1st of June. All his family were there, including Chloe. Chloe was there too. That was the day the bottom of my world fell out. And life changed forever. Grief is just like someone has reached in and ripped your heart out. There's just this big gaping hole that is there all the time. It follows you around everywhere you go. Every minute it's there. Some days are better than others. You know, some days you can put one foot in front of the other without feeling like broken glass underneath your feet. But then other days then are like day one all over again. support from colleagues, both past and present, I have to say, has been fab. You know, they know who they are, especially my boss, Lindsay. I know she won't mind that I name her. She's been my emotional support from day one, right from diagnosis. If she hadn't have been there at the end of the phone, I'm not sure what would have happened really, because just that need to offload almost, and that was her role, and she did it fab, and it's still continuing then. Stan's wish was for me to look after Chloe, because he couldn't be here to do it himself. So that's my main focus. Who knows? I may find myself again one day. That seems a long way off, but maybe.
On behalf of each and every one of us, I would just like to say a very heartfelt thank you to Elaine for being willing to share her story with us today, and in such a very articulate, powerful and meaningful way. We all know that death is part of life and something that affects all of us without exception. And that's true for our staff colleagues, for the patients that we serve, and indeed for each and every one of us here as board members. And so being reminded, I think, of the significance and the difficulties involved is really important. And it's certainly good to hear from Elaine as well of the support that she received from the various services, including health services, as she and her family went through that those experiences, and indeed continue to adjust to life without her husband. So a big thank you, Elaine, and thank you to colleagues who work in those important services. I'll just pause very briefly should any colleague want to come in with an observation or a response to that experience story before we move to the next agenda item. Okay, thank you. So we do move to item 1.5 of our agenda and to questions to the board. I mentioned earlier that we have this as a standing item on our agenda. We haven't received any questions from the public for consideration at this meeting, and therefore there is nothing to discuss in relation to this agenda item. And so we move to item 1.6 and to the update reports from myself, from Kirsty, the Vice Chair, and from Hayley, the Chief Executive. I will take my report as read, and I have no additional comments, but I am very happy to receive questions or for people to come in and raise any issue or ask anything in response to my report. Does anybody want to comment? No, thank you very much. And so we invite Kirsty then to add any additional comments or to present her report. Please come in, Kirsty.
Diolch yn fawr, Cadeirydd. Thank you, Carl. I'll take my report as read, but I just did want to take this opportunity to highlight and to congratulate Catherine Davis, one of our learning disability nurses who at the end of last year received recognition for her work in the RCN Nurse of the Year Awards, where Catherine was named as the Learning Disability Nurse of the Year. That's a wonderful, wonderful recognition for the amazing work that Catherine has done on behalf of our service users with learning disabilities in the county, and I just wanted to put on record all of our congratulations and our pride that we have in Catherine's achievement. Thank you.
Absolutely, Kirsty, and thank you for doing that. And I think it's really, really important, isn't it? You know, as our agenda will show today, there are lots of difficulties, lots of pressures on us as a health board, but it's really important not to lose sight of the brilliant work that Catherine and indeed others do across our organisation day in, day out. So thank you for that important point. Does anybody want to come in at this stage with a question or an observation in response to Kirsty's report? Okay, so we move to Hayley, our Chief Executive, for her report. Thank you, Hayley.
Good morning. Thank you, Carl. Most of the paper I'll take as read, but I just wanted to highlight a couple of areas, if that's okay. So firstly, in relation to stroke services, the report covers the decision that Cwmtaf Morgannwg University Health Board had to take to implement urgent temporary changes to stroke services at Prince Charles Hospital, and that took place from the 6th of January. The services have been transferred across from Prince Charles Hospital to the Royal Glamorgan Hospital. And this is down to workforce fragility and problems with being able to find stroke clinicians for the service. Just wanted to assure the board that we've been in discussions with Cwmtaf University Health Board, but also with the Neirin Bevan University Health Board and the WAST colleagues to ensure that we have put in place clear pathways for the patients and residents in South Powys. Wanted to also reassure that in relation to this, that for people self-presenting, that Prince Charles Hospital is still able to provide emergency assessment and treatment and thrombolysis. Clearly, we have an interest in this work and participated strongly in the previous review that was undertaken under the South Wales programme regarding the configuration of stroke services and clearly the strategic importance of Prince Charles Hospital. I've written to Cwmtaf University Health Board to remind them of our position on this and the reassurance that this is temporary in nature and that the discussions will take into account the previous work undertaken as part of the South Wales programme and the position of Prince Charles Hospital. Tied to that, Hywel Dda University Health Board are also meeting this week to discuss their refresh of their clinical services strategy, and colleagues will be aware that there are some initial discussions around particular scenarios that may result in stroke services at Baronglaes General Hospital changing to a treat and transfer, with inpatient services potentially provided in other parts of Hywel Dda at that time. Just wanted to reassure again the board that we will work alongside with our colleagues once we are clear about the options that are being developed for public consultation, and we will make sure that the communities in Powys will also be a part of that consultation process. Just wanted the board also to be aware that there is a more detailed paper coming through to the next planning and public health committee of the board, specifically to discuss the further information we should receive this week after the discussions take place in Hywel Dda University Health Board's meeting. The second matter I wanted to just draw to your attention is clearly the judicial review is now in progress regarding our emergency medical retrieval and transfer service, and 2 days have already taken place earlier this month in Cardiff Crown Court, and a further day of hearing has been scheduled for the 7th of February. And again, once we have further information to share, we will bring that back to the board. I think it is important because we have got a number of challenging issues to face as an organisation, that I draw your attention to the section that celebrates our staff. Kirsty has just mentioned Catherine, but also really pleased that Heather Wenban, our lead nurse for dementia, was awarded the British Empire Medal award earlier this month. Really excellent work. She was nominated because of the work that she has driven over many years to improve dementia care in Powys and across Wales. And then finally, you know, it's really important that we celebrate our staff. So just wanted to draw the board's attention to the Staff Excellence Awards being now open, and the importance of encouraging people to nominate under the available categories. Happy to take any questions. Thanks.
Diolch, Hayley, thank you. Colleagues, please indicate if you'd like to respond to anything in Hayley's report, and we'll go initially to Mick. Thank you, Mick.
Thank you, Chair. Mick Genasi, independent member. Hayley, could I just ask about winter pressures? So I'm referring to page 13 of the board book and page 4 of the report. I noticed that Powys achieved a 7% reduction in delayed transfers of care during the programme so far, which is clearly, you know, a very positive and welcome outcome. But as I read it, it's half the All Wales reduction of 14%. I just wondered if you could give us a sense of what lies behind that. Is it about the effectiveness of our response, or other situational factors which are unique to Powys, or is it just, as is often the case, statistics at play?
Thank you, Mick. I would ask Elaine Lawton to come in, who is leading this work, to respond to Mick's question. Thanks.
Bore da, good morning, everybody. Elaine Lawton, I'm the Exec Director of Primary Care, Community and Mental Health, the Health Board. I think what is always slightly difficult when we're looking at the pathways of care delay statistics, Mick, is that they are captured a day in a month. They don't capture the totality of the position that we face. We are facing from December through into January so far increased levels of pressure and demand from the need to enable patients to come back into Powys, whether that is to their own home or whether that's into one of our community hospitals. But as Hayley's report articulates, we have seen an increase in the number of admissions coming into our community hospitals, and that's about 25% more than the same period last year. So currently what we're looking at, certainly for the end of December and January, is a step up in terms of our ability to bring people back in. And we're also seeing a significant reduction, which is sustained, around the number of days that people were delayed. So at the very start of December, end of November, our average length of stay in a community hospital was 47 days for an individual. At the moment, we're averaging around about 42 days. And some days that goes down to sort of 34, 36 days. So we have seen us being able to support flow. We have seen us being able to step down all of those three domains that are being measured, but the pressure remains constant, and we face that from a range of organisations around us. So the areas that we are facing the longest delays at the moment are in assessment and then some of the care home packages that we are waiting for. But we are working hard, and we are working with our partners in the local authority in particular to try and resolve and move these forward. We have seen from within the local authority an increase in the number of care hours that have been made available to our Powys population. That happened at the start of December, and that was really welcome. But these are pressures, I think, that we do face, particularly in winter, but actually we see them throughout the year. So the work that we're doing, looking at rehabilitation, looking at how we are configuring our wards, looking at our flow team and our flow hub, and the work that they're doing is going to continue to be really important.
Nick, would you like to comment, or are you content? You're on.
Thank you. I just wonder, Elaine, is there anything that we can learn from others? You know, there is a significant variance there between our outcome and you know the general position across Wales. So I understand, you know, the work that's going on, I understand the challenges. I just wondered what the reason for the variance was.
I think there are things we can learn from others. I was at a National Care Action Committee meeting yesterday with the Cabinet Secretary, where each health board identified and reported on 2 of their highest priorities and areas of challenge. I think what we need to contextualise is that we're currently the 2nd lowest length of stay delays or delay days across the whole of Wales. So I think there are things that we can learn, but equally we're in a slightly different position within Powys with no district general hospital, and therefore we're working with a large range of providers who respond all very individually. So we have some complexity in how we learn and how we respond, but I think your point is well made there, and we will continue to do that.
Thank you, Chair. I'm content. Thank you.
Thank you. We go to Ronnie, please, Ronnie.
Thank you. Ron Alexander, Independent Member General. Hayley, as always, a very helpful report. Thank you. I have 2 questions. One, predictably, on health protection, and the other on judicial review. So if I may, I'll start with the judicial review and your reference to the fact that 2 days already have been expended on this, and there's a 3rd in the diary. So I just wondered, against the background that this obviously involves costs for the health board, can you see the way forward after that in terms of additional days in court, or is that likely to be the end of it? And then in relation to health protection, very interested in the last paragraph on page 4. The vaccination service has commenced the RSV catch-up programme, and appointments are offered at locations across Powys to ensure eligible residents are offered their vaccinations locally. I wondered about that against the background of the discussion at the recent Welsh Affairs Committee and the complexity of some patient journeys, although obviously the context for that is completely different. And given that there has been some degree of hesitancy for vaccines on COVID and flu, is there anything that we need to think about in terms of more local delivery of those vaccination clinics, or have we done everything that we can? Thank you.
Thank you, Ronnie, and I'll give Mez Bowley some warning to come in on the particular points that you've raised regarding RSV vaccination, etc. So if I start with the judicial review, clearly the additional day that's been identified as instructed by the judge is to cover the health board's opportunity to present our case. I'm not in a position to confirm whether there'll be further additional days added to this at this stage, but I wanted to assure the board that as part of the Joint Commissioning Committee, all 7 health boards are involved in this, and therefore the cost associated with the legal process and the judicial review is shared across all health boards. But Ronnie, unable to confirm whether additional days will take place. It will depend on how day 3 continues in court, but I will keep you posted. And clearly one of the issues we'll want to understand at the end of this legal process is the overall costs and expenditure that we've spent in with regard to the legal costs with the case. If I ask Mez to come in on the health protection issues, thanks.
Okay, thank you, diolch. Mez Bowley, Director of Public Health. So thank you, Ronnie. So in terms of the RSV vaccine, just to sort of remind really that is a new vaccine programme that's been sort of rolled out. And then what we've just started doing now is the catch-up in January element really. So we also have a routine programme. So as individuals turn 75, within about 3 months of that period, they should be offered that vaccine. So we do have 6 GP practices participating offering the routine programme. And then where the local delivery comes in, where those practices are unable to participate at this stage, then we're looking to offer for the routine vaccine clinics in those communities to make it accessible possible, and also bearing in mind the travelling involved as well. So we're trying to reduce that as much as possible. And then for the catch-up element, which is individuals aged 75 to 80 years old, predominantly through vaccination services. However, in terms of Brontleys and Newtown, we are doing outreach clinic, and the service as a whole is also continuously looking at data uptake and has increased its outreach sort of clinics across sort of Powys, and they vary in terms of the location. And then just to add really that the service has developed an equity plan as well, and that's looking at not just geographical but also groups of individuals where uptake may be lower, and to look at how we close the gap there as well. So I hope that's helpful, but happy to take further questions or provide further information.
That is helpful. Thank you.
Thank you, Ronnie. So we move to Robert Lewis. Thank you, Robert.
Robert Lewis, also independent member. Hayley, I'm referring here to the changes in the stroke services and the movement from Prince Charles to Llantrisant, and also the possible developments in Hywel Dda. I appreciate that these changes do not mean that there is not a service for stroke, but they do mean that the patient's going to be transferred unless they are self-presenting longer distances. And my question really is, what is the clinical impact of this additional journey? It may not be something you want to answer today, because it would also be true of Hywel Dda, but lots of people who are worried about this at a time when WAST recovery rates are already a matter of concern. In the meantime, thank you for the work you're doing in representing us, and we look forward to more details from the Hywel Dda changes as well. Thank you.
Thank you, Robert. And I would like to ask Kate Wright, our Medical Director, to come in to respond to the question that you've raised around the clinical impact and the concerns that our communities have about the access times.
Thank you. Good morning, everybody. Kate Wright, Medical Director. Yeah, thank you very much for the question, Robert. It's really important, clearly, and just to assure that we are watching and engaging really closely with the conversations, appreciating the fragilities in other health boards, then we need to be really sure that our patients continue to receive safe and the right care. The stroke pathway is quite complicated. I think there are 2 or 3 main areas. So people may be familiar that thrombolysis, so emergency clot busting treatment, can be really important, but isn't the only treatment for stroke. And it's equally really important that people are looked after on a stroke unit. So those are 2 of the key things that we are focusing on, along with Ram, who's our physio, our therapist, stroke consultant. In terms of the emergency thrombolysis, then given that there are 4.5 hours, there's a 4.5 hour window to that being given, then my opinion is that the treat and transfer model, which is well established, is very unlikely to have a significant impact on that. Clearly, people will then need to possibly travel further to a stroke unit, which may well be inconvenient in terms of travel times, but critical really is that they are in a stroke unit and having the right dedicated, focused stroke care immediately after the stroke. So those are the 2 areas that I think are most important. Then really importantly, then we have also established our more focused and dedicated rehabilitation units in Powys, which will mean that we are more able to pull our patients back into Powys for their ongoing rehabilitation, which is really, really important. It is something we're watching really, really closely. There are other areas as well that we can possibly influence. There is something called pre-hospital video triage. We know that a lot of people with stroke symptoms may not be having a stroke, and there is something really important about making sure as we can that our patients get to the right place straight away. So that's something that is being explored. And in the meantime, just really important to emphasise that if people are experiencing symptoms of stroke, that's face, arms, speech and time, then they should dial 999 immediately and will be transferred to the appropriate facility. So I think just in summary, that it is something we're watching really carefully. I think that at the moment, the treat and transfer system is well established, but it's something that I think how the whole system and how not just the individual health boards, but how the whole system responds is going to be really, really important. And we are closely involved in those conversations as well.
Thank you, Kate. Robert, anything additional or anything supplementary from you?
No, thank you, Chair, for a very thorough and detailed response.
Thank you. So, Chris Walsh, please come in.
Well, thank you, Chair, and thank you, Hayley, for your report. Chris Walsh, Independent Member, Local Authority. Again, I wanted to just pick up on the stroke services first of all, and then coming on to the vaccination programme regarding the RSV, and just mention about winter pressures, if I may. In relation to stroke care, obviously this has been a topic of conversation that's come up on a couple of occasions. Within the report, it says that this is going to continue for some time. One of the questions that has been raised is, do we have any idea of what that timeline looks like? Because that may help give some reassurance in some ways. Then in relation to the self-presenting patients going to Prince Charles Hospital, bearing in mind the response that's just been given by our medical director, are we saying then that if an ambulance is called and they take them, they won't be taking them to Prince Charles Hospital, they would be taking them to a different location? I know that would be based on clinical need, but if time is of the essence, surely taking them to the Prince Charles Hospital, if that thrombolysis action was available, would be the right approach. And I just wondered whether that could have a response in relation to that. Then in relation to the RSV vaccination program, it is a new program and some people are unfamiliar with it. Can we just have clarification around the eligibility for that program? I think that would be helpful on there. And then obviously in relation to the winter pressures, I look for little chinks of positivity, as Carl had indicated in his thing. We were working in challenging times, so the one bullet point which goes about the number of delays that have been occurred is the second lowest delays in 9 months, and whilst this is a positive move, it's still too high. I think that is showing a little bit of encouragement, and I think that we should latch on to that. And something then within your report, Carl, you mentioned about DigiFlow, which is a shared platform regarding Powys County Council of understanding delayed transfers occur. And I just wondered whether that gives us any greater opportunity to be making any headroom within that area. And I'll stop there, Chair. Thank you.
Thank you, Chris. There's a lot there, Chris. I'm conscious of where we are on the agenda and so on. So clearly, very important points, Chris. Hayley, if I could ask that we try and be as succinct as possible now.
Yeah.
I think, Kirsty, do you still want to come in? I was going to come to you next and then conclude this agenda item. So we'll see. Please, Kirsty, yes?
I just wanted to go back to the point that Elaine raised, and I just wondered whether Elaine could give us an update on whether we have made any progress on a trusted assessor model. Many of the delays are around assessment. The expectation is to have a trusted assessor model to streamline that process. I'd be grateful for an update. Thank you.
Thank you, Kirsty. So, Hayley, we'll come to you, and then, unfortunately, Ian has got one or two functionality issues, but I understand that he does want to contribute as well to this agenda item. So we will go to Ian, and then we'll move on our agenda. Thank you, Hayley.
Thank you. With regard to the timeline, Chris, I'm unable to give further assurances about how long the temporary change will continue by Cwmtaf University Health Board, because it is reliant on their ability to secure a workforce. So unfortunately, I don't have a timeline to share, but I know that they wanted us to be clear that they don't think this is going to be resolved quickly from the point of view of the ability to recruit to the workforce. So that's the first point. Just want to reassure that the work that we did around modelling the stroke pathways, we looked at the number of strokes we've had, and we've always agreed with WAS they will take them to the nearest available DGH where the appropriate treatment is available. And for us, the majority of our patients will not be going across to Llantrisant from the location where they're coming from in Powys, because it's where they pick up the patients is part of the discussions that ambulance decision making around conveyancing. They will be going to the Grange in and near in Bevan University Health Board. So we've assumed the pathways will be to the nearest DGH. With regard to RSV eligibility, my suggestion is, if it's okay, Chris, we can share that in the report with you, probably in the sidebar. Every member of the public can see that. And then I will bring Elaine back in just to give a little bit more assurance around there are definitely green shoots, Chris, and it's really important people are working very, very hard operationally to do the best they can to reduce delays and to deliver against the 50-day challenge. But it's the scale of the change that we need to do is substantial. And I do think that DigiFlow will help us to have that real-time information, that shared understanding of the information that's available. But I'll ask Elaine just to come in to give very quick additional information in response to those points and trusted assessor. Thanks.
Yeah, so thank you, Chris. I think you're right. DigiFlow does give us a mechanism to enable us to share information more clearly, for that to be visible and for us to develop. That's a system that we can configure. So it is implemented at this point in time. Staff are using it, but I think there's more we can grow, and it's still early days. So I think it's a well-made point, and we'll continue to develop it and report back on it. In terms of trusted assessor, just to confirm that we do have a pilot for trusted assessor working from Cottage View, our residential care home. That is progressing well, and I've asked already this week that we can pick up some learning from that and see how we can extend that more broadly. I think green shoots, I'm really pleased, Chris, that you picked up on green shoots. I think that they are there, but I think what we've got to do is make sure we care for them and ensure that we can grow them into something much stronger, something much more sustainable, because this isn't a challenge that we've accomplished. It's something that we're going to have to continue to work through with clear focus and intent.
Thank you, Elaine. So on this item, we're going to go finally to Ian Thomas. Please come in, Ian. You're on mute, Ian. Are you having difficulties unmuting? Okay. Yeah. No, I think that's done it.
Okay. What is that, Pope? Can you hear me?
Yes. Yeah.
Oh, good. Okay.
Oh, no, you've gone back on mute, Ian, I'm afraid. Okay. No. There's clearly some gremlin in the system. I'm really, really sorry, Ian. Please hold on to your comment, and we will look for an opportunity later on in the meeting for you to make it. In the meantime, colleagues will liaise with you to try to sort out the technical glitches. And so thank you for that. And thank you, Hayley, for your report and for the very important matters that it raises that has given rise to some very important conversation. Thank you. And so we go now to item 1.7 of our agenda, a dyn ni derbyn rwan adroddiadau o'r gwahanol pwyllgorau a'r is-bwyllgorau, yr is-bwyllgorau sydd gennym ni fel bwrdd, ma'n hwn dyna lle mae'r gwaith craffu manwl yn cymryd lle, felly maen nhw yn ffynonellau arwyddocaol iawn o sicrwydd i'r bwrdd, ac mae caderyddion y pwyllgorau hefyd yn geidwaid pwysig iawn o'r sicrwydd hynny. Our subcommittees as a board are very, very important places where the detailed scrutiny of performance and of our operation takes place, and the reports we receive from those committees therefore are a very, very significant source of assurance for us as a board, and the chairs of those committees therefore as custodians of that source of assurance. And so we're going to go through each committee in turn and invite each chair to present that report to us. We go initially to our Audit and Risk Committee and to its chair, Steve Elliott. Thank you, Steve.
Good morning. Thank you, Chair. I'm Steve Elliott, the independent member with interest in finance. Just a few points to highlight from our recent meeting. In terms of internal audit, we did agree one change to the plan for the current year, and we also noted that the plan for next year is being developed. It's pleasing to note that of the 7 internal audit reports that we considered, 3 had received substantial assurance ratings, and 3 had received reasonable assurance ratings. The findings and recommendations from the limited assurance report on deprivation of liberties safeguards were accepted by executive colleagues, and management action has been agreed. We also had some useful updates from Audit Wales, Counter Fraud, and the post-payment verification team. And finally, I'd just like to say that we received an update on the significant amount of work that's been done to address the recommendations from the 2019 Limited Assurance Report on records management, and it's really pleasing to note that area now has received a substantial assurance rating. So that was warmly accepted by the committee. Thank you.
Thank you, Steve. Colleagues, does anybody want to contribute or come in at this point in response to the ARAC report? No, so thank you, Steve, and to your committee colleagues. We go now to the Powys Health Charity, the Charitable Funds Report. This is a committee that I chair, and we have a report here that deals with our meetings both on the 2nd of December and the 10th of January. I don't have any additional comments to make to the report, but I am happy to take any questions or observations. Does anybody want to come in response to the Charitable Funds Committee report? No, so thank you. And of course, we will be coming to that in a few moments in terms of its annual report and accounts. So we go back to Hayley and to the Executive Committee report. Thank you, Hayley.
Yeah, thank you. This report covers the activity of the Executive Committee. We meet broadly on a fortnightly basis, and you can see the report covers the items considered of the last 6 meetings. I'm not planning to summarise the report, colleagues, but you can see from our agenda that a large number of the items that we considered in the Executive Committee routes then through to the relevant committee committee and board. So I'm more than happy to pick up any questions people may have on the content of the report, recognising the breadth of it. Thank you.
Thank you, Hayley. So colleagues, please do come in if you have anything to ask or comment on in response to the Executive Committee report. There are none, so thank you very much, Hayley. And we turn now to Ronnie Alexander, Chair of our Delivery and Performance Committee. Thank you, Ronnie.
Thank you, Carl. This report consists of 7 pages, which I think says something about the depth and complexity of issues with which the committee deals. I unfortunately could not attend this meeting, but it was chaired very ably by Robert in my absence. Just to reference 1 or 2 important items, particularly, we did have an important report on the organisational status, the NHS Wales escalation framework and the enhanced monitoring report. We received that report as part of a package of assurance that Powys Teaching Health Board continues to report as required in relation to its organisational escalation status. In relation to the finance report, that of course relates to month 07, and whilst there was a very detailed examination of those financial figures, they have been revised substantially since. There was also consideration of the integrated quality and performance report for month 7. And overall, it was felt that performance across Powys had been maintained, but cancer and other issues remain a challenge. If I might just turn briefly to community pharmacy and the annual report there, the committee received the report which demonstrated significant progress across the 12-month period to strengthen performance and quality contract monitoring. But there is an increased trend of contractors submitting requests to reduce their opening hours, and electronic subscription services are set up in 4 practices with an additional 3 onboarding next year. So there are a number of challenges that exist within that particular dimension. On general dental services, access to general dental services, GDS, continues to be a local and national challenge, and I mean national in the widest sense. And supporting patients to access appropriate GDS provision continues to be a high priority for Powys. And I think at that point, I will pause, but happy to take any observations or questions. Thank you.
Thank you, Ronnie. Colleagues, are there any comments, questions in response to the Delivery and Performance Committee report? There aren't any, so thank you, Ronnie, and indeed to your committee colleagues as well. Robert, would you please speak to the report from the Performance Partnership Public Health Committee report, please?
Thank you. This is the 14th of November meeting, so in many cases things have moved on considerably, or those items appear at this meeting. So that covers strategic change, the integrated plan, of course, for 25-26, the route map to sustainability, and also the winter respiratory vaccination campaign, which of course carries on. But there was something I wanted to mention, which is that the committee took assurance from a health programme called Design to Smile, which was centred around children's dental health. Other than that, it is as it says, and I'd be happy to answer any questions. Thank you, Chair.
Thank you, Robert, and forgive my rather clumsy way of introducing that report. It is, of course, our Planning, Partnerships and Public Health Committee. But thank you, Robert. Again, colleagues, please do indicate if you'd like to respond to the PPPH report. No, so we move on then to Jen. I'm just hoping that Jen Actually, Jen, you are with us. I know that you had some connectivity issues earlier. So Jen is chair of our Workforce and Culture Committee. Over to you, Jen.
Bore da pawb, yes, and thank you. I'm happy to accept that taking the paper as read. You'll see some of the main themes that have come out from our meeting on the 10th of December. Hopefully that's self-explanatory, but very happy to take questions. Diolch, Carl.
Thank you, Jen. Does anybody want to ask a question, make a comment? No, so thank you, Jen, once again, and to your committee. Finally, but certainly not least, we go to a verbal report from our Partnership Forum and to our Executive Director, Deb Wood-Lawson. Thank you, Deb.
Diolch, bore da, everybody. This report today is just a list of the agenda items in that the meeting only took place on the 20th of January. A fuller report will come to board next time. Some of the items on our agenda within the last local partnership forum are standard, finance, my director's report, but there were two that I will just reference. So we received a lessons learnt on the temporary service change. So that was looking across the things that went well and the things that we need to build into a future approach around leadership, governance, assurance and communication and engagement. So lots of good examples, and we're working with staff side to consider our future approach to any forthcoming changes that we may need to consider. We also received an update on the administrative review, which was in relation to data, the skills being undertaken by teams, the locations they worked in, and how we help support the career development of this critical kind of business support activity, and recognising that we need to kind of focus in on a few main areas, and the areas we've agreed as an executive support. That was all I was going to say, Carl. Thank you.
Thank you, Deb. We lost the tail end of your words there. I think we were having some connectivity issues, but I think we got the vast majority of it. So thank you very much for that. Again, does anyone want to offer a comment, ask a question, contribute in response to Deb's oral report following the meeting of the LPF? No, thank you. And so very importantly, it is occasionally needed that our committees escalate matters to us as a board, either for our awareness or indeed occasionally asking us to take some action. And we keep a record of those escalated matters, and therefore we monitor what's happening to those escalated matters. So I'm going to invite Helen Bushell, our Director of Corporate Governance, just to summarise where we are in relation to those matters. Thank you, Helen.
Bore da, everybody. Thank you very much, Carl. So just to confirm, as per the cover report, then there are three areas all which sit underneath the remit of the Patient Experience, Quality and Safety Committee that have been escalated to board. These are not new items. They've been on the board awareness for some time. They relate to infection prevention and control, neurodiversity services, and issues in relation to our patient experience system, Civica, in terms of our internal capacity. Carl, there's nothing new to escalate to the board. They are there for the board's awareness, as you said, in the context of making sure that those matters are absolutely clear. All three of those are subject to further consideration by our PECS committee in about 2 weeks' time. So there'll be a further report back to the March board. So nothing further to flag at this stage. Thank you.
Thank you. Very helpful, Helen. Thank you very much indeed. I will come back to item 2 on our agenda, but I want to move now to item 3.1 because we have a couple of colleagues from Audit Wales, Mike Jones and Jill Howells, and I know that they've been waiting patiently for this agenda item, and I don't want to keep them waiting any longer. And so item 3.1 is the charitable funds and annual report and accounts. I chair, as I said before, the Charitable Funds Committee. This was considered by that committee on the 20th of January, and the recommendation from that committee is that the report and accounts are approved. But I'll initially ask Pete, our Director of Finance and Deputy Chief Executive, to introduce this item, and then to bring in Mike and Jill afterwards. Thank you, Pete.
Yeah, thank you, Carl. Good morning, everyone. Pete Hopgood, Director of Finance. As Carl has introduced, these are the annual accounts and the annual report for our charitable funds for the period ending the 31st of March 2024. As Carl has already highlighted, these accounts and reports have already been approved by our Charitable Funds Committee and are brought to board for approval. Worth noting that detail as included in the report in terms of our level of spend, our level of income and the current balance of our funds held are all included. Pleasing to note the good audit report that we received, and it's probably timely at this point to ask Mike to come in and to comment in terms of the ISA 260. Thank you, Mike.
Thank you, Mike, and thank you for your patience. I know you've been waiting a long time.
Oh, that's fine. Thanks, Chair. Thanks, Pete. Good morning, everyone. As Pete has just highlighted, this has been discussed, presented at the Charitable Funds Committee, so I'm not going to do that again, but it's your opportunity, I guess, as trustees, just to ask any questions if you had any. In summary, it's a very positive report. There's very little findings, if any, and no significant issues to bring to your attention, and importantly, an unqualified audit report will be given by the Auditor General either later today or tomorrow following your approval of these accounts. So happy to take any questions, but I won't say any more because it's been taken in detail at the committee.
Thank you, Mike. And just to build on your comment, so it is here for our consideration because the charity is an arm's length charity of the board. We are the sole trustee of that, corporate trustee of that charity, and therefore ultimate accountability and responsibility lies with us as a board. So does anyone want to come in with a comment and so on? Ronnie, please.
Thank you, Carl. I think this is a very clear report. I have a question, not in relation to the report itself, but a question arising from the report. So is it appropriate if I raise that question now, or would you wish me to hold it until later?
Well, actually, if we just hold just for a second, Ronnie, let's deal with the recommendation per se, and then if it's okay with you, I will come back to you immediately afterwards.
Of course, thank you.
So does anyone want to come in terms of the report and the accounts? If not, then the recommendation is that we receive and approve.
Carl, apologies. I think Hayley wanted to come in.
Sorry, Hayley, I missed your hand.
That's okay. It was really a comment. From my perspective, no issues with the annual report and accounts for this year, but the distance that we've travelled around the charity is really clear for me from the previous year's reports that we've considered, and I just wanted to put on record my sincere thanks to the staff who are running the charity and to our finance colleagues for putting us in a position where we've got such a positive annual report and accounts to look at today. Thanks.
Thank you, Hayley. So the recommendation is that we receive and approve the Charitable Funds Annual Report and Accounts for the period to the end of March 2024. This is recommended by the Charitable Funds Committee, and we receive and approve the Audit of Accounts report from Audit Wales. Does anyone want to indicate that they don't support that recommendation? So that is supported unanimously, and I, in this forum, as I did in the Charitable Funds accounts, also want to express gratitude to Mike and colleagues at Audit Wales and to acknowledge the constructive and positive working relationship that exists between ourselves and Audit Wales, which is very encouraging and very assuring. So thank you, Mike. Mike, I don't know what Ronnie's question is, and so let's take that, and because it may be that that you're well placed to comment on it, but let me invite Ronnie to come in and make his observation. Thank you, Ronnie.
Thank you, Carl. I don't think it's a particularly complex question, but my observation would be that having looked through the document quite carefully, and I'm entirely open to correction on any of these points, some 300,000, just less than, came into the accounts, and some 40,000, just more than, was spent on staff initiatives and staff training. So my question is, consistent with the charitable aims and the governance around that, is there anything more that we should be doing to support and train staff, given the particular importance that they have to all of us, particularly delivering in this time of huge financial challenge? Thank you.
Thank you, Ronnie. Can we hold on to Ronnie's question, please? And I'll invite Mick as well to make his contribution before inviting a response. Thank you, Mick.
Thank you, Thank you. I just wanted to just reinforce Hayley's comments about the progress. So this is, I've been with the board for around about 12 months now. This is one of the first reports that I saw when I joined the board, and I asked a number of questions about the report, and I'm really pleased to see that all of those things have kind of moved on in a very positive way. So, you know, the return on the investment, the way that the funds are used, the focus on patient services and additional value. Also, the proportion of spend and the distribution between administering the fund and actually, you know, providing value through the fund. I just wanted to reinforce Hayley's comments that just feels like a real step forward. So thank you.
Well, thank you, Mick. So back to Ronnie's question. Pete, do you want to offer a comment or invite somebody else to?
Thank you, Carl. I think it would be helpful if Deb comes in on this point.
Thank you. It's a really good question, Ronnie. Thank you. There's always careful consideration around what is provided from the centre, so from your core budget and where we might need to seek some additional funding. So one of the areas that we did reach out for charitable funding was refreshments in some of our wellbeing hubs. But just as a reassurance, we have a wellbeing at work group. We have benchmarked our activity against Health Improvement, Health Education Improvement Wales Wellbeing Best Practice Guide, and we know that our offer to our staff is considerable and it's comprehensive. What we need to do is make sure that all staff are accessing that. I hope that helps. Happy to take any further questions. Thank you.
Thank you, Deborah. I am reassured. It was just a question, it was just an observation that perhaps there should be an element of heightened sensitivity around all of this. Thank you.
Thank you all. So if there are no other questions, we've already supported the recommendation. Thanks once again to Audit Wales, and we conclude that agenda item. Thank you. So we go back now to item 2. It has been our practice now for a few meetings to operate a consent agenda, and it, essentially you will see this later on in the agenda as item 5, and this is a list of agenda items that are considered not controversial and that don't necessarily need discussion or conversation here, but clearly do need either noting or approving and so on. And so when we get to item 5, we will take all of those items en bloc without discussion. But it's always possible for board members to request that any item within the consent agenda be brought into the main agenda should you think that it does need discussion and more detailed consideration. And so the question is, Does anyone want to suggest that we move any item from item 5 up on the agenda? No, so when we get to that item, we'll deal with it as I've described. Our next item, therefore, is item 3.2. And just before we come to that item, I'm going to suggest, because we've taken some time, very importantly and very rightly, on some of the issues so far. So I'm going to suggest that we just take a 5-minute comfort break before we get into item 3.2. And so if we can come back in 5 minutes, which is 10, I'm rubbish at this, 10:52, no, 11:02, I think.
10:58, Carl.
10:58, thank you. I was never good at those things. So thank you, Helen. See you all in 5 minutes. So colleagues, welcome back. It is 10:58, so we will reconvene. I just want to make sure Helen will indicate if she thinks that we're good to go. Thank you, Helen. And so we turn our attention to item 3.2, next steps in relation to the annual delivery plan, and this was considered at a board development session on the 17th of December, and of course it was subject to focused discussion, as I mentioned earlier, at our extraordinary board meeting held on the 10th of January. So we're not going to rehearse all the information and so on that was shared and discussed on the 10th of January, but I will turn to our Chief Executive, Hayley, to introduce this update. Thank you, Hayley.
Thank you, Chair. So yes, this paper summarises the work we've undertaken since the meeting on the 10th of January to support the delivery of the Health Board's forecast deficit plan by the end of the financial year. As we discussed in our meeting on the 10th, the Health Board reported at month 8 an overspend of 16.3 million compared to a 10.5 million year-to-date financial profile, which is against the revised full-year deficit plan target of 15.8 million. We calculated a variance of 9.4 million against our plan and presented at that meeting a range of mitigating actions for the board consideration. At that meeting, we agreed to initiate a vacancy recruitment freeze, and secondly, to reduce our reliance on the use of agency and locums. So the first part of the report sets out the immediate actions we have taken to implement these during the last 2 weeks, in particular in relation to both in and out of hours, the process for approval around agency and locums, and vacancy controls. The board also agreed that further work should be undertaken in discussion and in partnership with NHS England providers in order for us to assess the options to revise elective activity. We also needed to finalise the integrated impact assessment to give the board a full picture to inform our decision making. We've also assessed our overall delivery confidence, and I just want to give assurance to the board that all of this work has been undertaken in firm dialogue with our English providers. So during the last fortnight, Pete as the Director of Finance, Nicola as the Director of Commissioning, and I have met with the 3 main providers. Those 3 main providers are Robert Jones Agnes Hunt Orthopaedic Hospital, Shrewsbury and Telford NHS Trust, and Wye Valley Trust. I also wanted to inform the board that we also have met with colleagues in the integrated care system, and we've laid out and discussed the assessment and impact of the commissioning options that we were considering during Q4. So I'm really grateful, before I go into the detail, to the way in which our colleagues across the board have responded to our request to work in partnership. They have been open, willing to discuss with us, and very constructive in their approach. And I think I'd like to particularly thank the commissioning team for their work in developing these long-standing relationships over many years. And I think the way in which they've been willing to work with us on this matter has and is a testament of the mature relationships and the valued relationships we have in place with our English providers. So I wanted to remind colleagues of the 2 scenarios we were testing. We were testing the same planning assumptions consistently across all 3 providers, and you'll see those in the page 6 of the report. The first option involved deferring patients who haven't yet been booked for their appointments, and the second option included deferring appointments which were already booked from the week commencing 3rd of February. The implication of deferring this activity is that patients could wait longer by at least 3 or 9 weeks, depending on the scenario considered. Both scenarios excluded cancer pathways, under 18-year-olds, patients on surveillance, and also those who had, through the initial triage and assessment, been identified as being an urgent appointment. And I just wanted to confirm that in the majority of the cases, patients would be seen in line with Welsh waiting times targets. So the paper details the current assessed total financial impact of the two scenarios. Scenario 1 offers a 924,000 opportunity, and scenario 2 just over 2 million. The providers supported our completion of the final integrated impact assessment and delivery confidence assessment. And some of the key factors that were raised and that we discussed included, first, the administrative burden and costs of contacting and rebooking patients. Providers indicated that there may be an inability to rebook into core capacity at short notice. There was a risk of stranded costs that cannot be recovered by the providers from other commissioners in the short term. And then the greater costs of implementing the change, which has also been reflected in the overall assessment. So attached in the papers is the final integrated impact assessment, and I'm really grateful to all clinical directors who have led this work, and also for our NHS England providers' input in finalising the content. So to summarise the integrated impact assessment, the proposal does increase waiting times for a significant number of patients, but I do want to make it clear that in both scenarios that the majority of patients would still be seen in line with Welsh waiting times targets. There is a small cohort of patients awaiting spinal pathways at Robert Jones Agnes Hunt, and those patients are already not meeting either the Welsh or the English waiting times targets. So the options being discussed to delay treatment in the NHS England providers does not mean that patients would be worse off than those patients who currently receive their care in the system in Wales. You will note from the integrated assessment that there's limited equality detail available within the waiting list information, and therefore we have assessed the potential adverse equality impacts based on what we have available to us. So firstly, age has been a factor, with a higher proportion of those patients waiting being over the age of 65. We've identified socio-economic factor, which is about identifying that delays to treatment may have an impact on individuals unable to work whilst awaiting treatment. And third is for carers. We know that further delays to treatment may have an impact of increased pressure or stress on carers. Overall, the delivery confidence assessment demonstrated, and you'll see that within the report, that across domains of clinical, financial, corporate, operational and reputational, we have a number of risks and significant impacts to consider. And this has resulted with the detailed work undertaken still in an overall assessment of delivery confidence remaining low. So as an executive team, we've balanced the details relating to the financial opportunity of this action together with the findings of the integrated impact assessment and the delivery confidence assessment to inform our recommendation to the board. A key factor is we are in Q4, and we've discussed earlier about the substantial winter pressures and operational pressures being faced across the whole system, but particularly for our acute providers. And another key factor is how we continue our excellent working relationships with our English providers as they provide for us not only the elective care for our population, but also emergency care. And we also rely on our partners for their input to sustain a number of in-reach services within the county. So it would be fair to say that the legal, policy and ethical considerations are substantial, and we are balancing some complex statutory duties and considerations. So therefore, as a result, I'm recommending that the board does not approve the decision to implement changes to elective activity during Q4. Thinking of next year's plan, which we will be considering in our March meeting, we know we commission a substantial proportion of secondary and tertiary care services for the residents of Powys, with neighbouring health boards across Wales and England. And we shared in our meeting last time that the activity accounts for over 40% of the health board's cost base. So to deliver financial sustainability will require us to review our approach to commissioning, as well as our continuous focus on delivering efficiency, productivity and sustainability of the services that we provide in the county. The other factor I wanted to draw to the board's attention is that we really need to think about how we can change the shape of future demand. It is key within our strategy and our duty also, alongside providing excellent healthcare to our population. We have a duty to improve population health outcomes. So how we shift our attention towards prevention and maintaining strong primary community and mental health services, as well as having an affordable commissioning plan, will be the subject of the discussions in our March meeting. So lessons learned, I wanted to mention around this process this year, and what we found that our commissioning activity is not in line with the planning assumptions that we set at the beginning of the year. I wanted to give assurance to the board that we're collating internally lessons learned around this to inform our approach, but also we're in early discussions with Welsh Government as part of the level 4 escalation to assess our current and future approach to commissioning, and I personally really welcome this additional level of scrutiny and support. I appreciate, colleagues, this is a challenging situation, and the recommendation to not proceed is based on a balance of risk, impact and consideration across all of our duties. As a board and as accountable officer for the organisation, I know we are all really acutely aware of how serious a financial situation we are facing, and it is very uncomfortable that we are unable to deliver our board approved financial plan. The context of this is really important, and I feel it's really important that I raise that I'm extremely proud and I acknowledge the incredible dedication and hard work of our current staff and partners in ensuring we are on track to deliver against our original savings target that we set at the beginning of the year of 9.9 million, which is the highest level of in-year savings that we have set for the organisation. And I also understand that, subject to the board's discussion and decision today, that we will need to take steps, including my need to potentially write to the accountable officer to Welsh Government, explaining our current position, our rationale for the discussion and decisions that we take today, and then depending on our decision, we'll need to revise our financial forecast for the year end. And this letter would also need to pick up, subject to the board's decision, an updated request for additional strategic cash support from Welsh Government to enable us as a health board to cover our financial commitments during the remaining quarter of this financial year. So I appreciate that was a lot of an introduction, and I'm keen to now take any questions you may have. And I know as an executive team, I'm really grateful to colleagues for the work that they've done at pace over the last 2 weeks to bring this recommendation through to the board. Thanks.
Thank you very much, Hayley. And so We have some colleagues that want to contribute to this, to the discussion about this agenda item, and we'll go firstly to Kirsty.
Thank you, Carl, and thank you, Hayley, for your update this morning. And can I echo your thanks? I know that the team have worked very, very hard since our last board meeting to respond to the requests of the board for further work, so that we were in a position to make a decision today. So I want to acknowledge that. And I think that work has been worthwhile because it has been able to give us a more rounded set of data on which to make this decision. I am fully supportive of the recommendation from the executive team contained within the paper, but and I welcome that in terms of the impact that that decision would have had on patients and the impact. I am particularly struck by what you said, Hayley, about how we can strike a balance between focusing on, quite rightly, the demands of patients in the here and now, but actually how we can, in amongst all of this pressure, turn some of our attention to population health, so that we can try and dampen demand by keeping people healthier and attending to their well-being. So I'd be interested to hear how we can try and create that balance as we move forward. And I'm also interested whether you feel that there is also an opportunity to look to see what we can do more in primary and community care within our own borders, that will actually perhaps lessen demand on services out of county, which can be really, really challenging. And finally, my third point is, as we think and as we engage in our planning for the new financial year, some of these issues that have perhaps taken our plans off track this year, that is performance across the border, what initial thoughts do you have on how we can plan in a way that prevents us from finding ourselves at the end of the financial year in these difficult circumstances? Thank you.
Thank you, Kirsty. Hayley?
Yeah, thank you. Really important questions. And I'll start a response, but I'd be keen for Mez to come in and perhaps Elaine on primary care and as well, and any other colleagues that may want to contribute. But I think this is our most challenging position, which is how do we strike the balances, and it's not straightforward because we are allocating our resources where there is current need, and clearly the need to shift how we allocate that resources is one of the key challenges that we're facing. And but I think we've got a very strong policy context to support this discussion. We know that we need the front door of the NHS is our primary care colleagues, and we know that the majority of our patients have access to primary care, and we need to further build that. And we have over the years taken a number of opportunities to do more in county, which is why I raised in the assessment of the balance of risk, which is how do we actually also protect what we already deliver in the county from a primary community mental health perspective, but also the in-reach potential of utilising and providing more locally within the county. The position, I will ask Mez and others to come in, but I think that the position around how do we avoid this and prevent this scenario going forward, I mentioned to you earlier about lessons learned. I don't think we would have predicted the level of productivity and recovery that we've been able to benefit from for our population in Powys, and the pace of that recovery in NHS England. And I think in the last year, particularly the elective recovery funding and the impact of that has had a substantial impact. So to prevent this going forward, when we talk about next year's plan, plan, I think we'll be talking about the most likely scenario, the worst case scenario, and the best case scenario. And we will then, as a board, need to take a decision in discussion with Welsh Government about the really difficult choices we'll need to make as a result of that. So the planning assumptions, we'll have the learning from this year, so we'll reflect on that. And I think particularly on growth, Kirsty, and the scenarios around growth and how we plan for that activity. And then we will need to decide, and this is the fine balance between having an ambitious plan to deliver financially and a realistic plan, and being in level 4 escalation, having those conversations alongside Welsh Government over the next couple of months before we submit our plan is, I think, critical to our ability to manage next year's plan and to avoid needing to take additional actions in Q4. I think the other issue is our emergency activity. So again, you know, that there have been increases in our emergency activity as well, particularly same-day emergency care has been an issue, not just in England, but also in Wales. And there will be particular actions, talking back to the conversation we had earlier about how do we continue to have a greater level of impact on pathways of care delays. You know, getting our activity and flow sorted will be absolutely essential in order to curtail some of our emergency activity as well. But perhaps, if it's okay, Kirsty, I'm keen for you to hear from Mez, our Director of Public Health, and Elaine around the opportunities in primary care. Thanks.
Thank you, diolch, Hayley. So, yes, so in terms of population health, absolutely important, and is a statutory duty for us as well. So our annual plan does have sort of well-being as the sort of first sort of strand within our plan, but it'd be fair to say really that that needs to be strengthened, and we need to look at the balance of our plan there. So in terms of, one of the phrases is the prevent the preventable element really, and we can do a lot around that work in partnership with our partners, also with primary care and community there. I've mentioned before that a third of our population will be over 65 in about 10 years' time. So there's work to be done really to look at how do we keep those in our 40s, 50s and 60s healthy, to prevent those chronic conditions and delay some of those from occurring element there, to keep people healthier for longer. So that is a piece of work that we need to look at to support our communities and enable individuals to keep sort of healthy. But equally, when we develop those chronic conditions, absolutely crucial then that we provide that support where individuals may have multi-chronic conditions to manage and live well with those conditions. And Elaine might want to come in there element. But also important, I just want to highlight really that giving children the best start in life is absolutely crucial. Those first 4 or 5 years of life, absolutely key for development, but also in terms of establishing good health to prevent some of those conditions happen. So in terms of next year's plan, I'm keen to to strengthen those 2 areas and follow through as well for those population level programs. So Elaine, would you like to come in? Thanks.
Yeah, thank you, Kirsty. So it's a really important point to make, and I think it's critical that we recognise that between 85 and 95, dependent on person, of the health care that our population receives already happens in primary and community services. So we are our population are accessing secondary care services outside of Powys for really important but quite short portions of their life and their time. So ensuring that we have strong primary and community services to deliver for our population, starting from that preventative and proactive care across their whole life journey and care pathways, is critically important. So there's 3 pieces of work I think that we're looking at. So the first one is working particularly with our GP practices, all 16 of our GP practices, and looking at their levels of sustainability and escalation, and making sure that we can work with them to get to a place of equitable, sustainable delivery, so that any further changes that we can make have an equal impact across the whole of Powys for all of our population. I think the second, and this is very much a focus that we've started and will be moving forward with even further next year, is of the elective care services. What is it that we can do to strengthen our delivery within Powys? And again, repatriate or bring patients who may be experiencing services outside of Powys back in. And our areas of focus there are looking at ophthalmology, musculoskeletal, and also referral management. And I think as much as we would like to do everything, we've got to recognise and prioritise some of these areas of work because they're quite a significant workload activity for us to review. So we're prioritising those areas where we've got the largest potential impact to make first. And then finally, I think there's the element of the emergency care that our population need, particularly our frailer population, those people whose health and care needs might be growing. So again, looking at how we can review some of the virtual world and community resource teamwork and some of our frailty schemes so that we can make sure that those are equitable and stronger and have a better chance at creating that confidence across the whole of the system for our population. So that's not purely about health, that's about how we work with the third sector, it's how we work with the local authority as well, and with our population in their communities to make sure that there is a greater ability for us to manage care at home. So we've been starting the initial planning work on all of those elements, and I think those are going to be critical and will need to build over time.
Thank you all. I can see that Nicola Johnson, our Executive Director for Planning, Commissioning and Performance, is it on this point, Nick? If so, please come in.
Yeah, so thank you, Chair. So to say that obviously we are working really hard in the development of our plan to lay out that strategic commissioning plan to support all of that work that Elaine and Mez have outlined. So there's certainly a strategic commissioning element to it in terms of bending that curve of demand, which Hayley has referenced. In terms of our more tactical commissioning, I just want to give some assurance to the board. So if you look at, for example, our planning for last year, and particularly in our NHS Wales contract, other than the SDEC issue, which has transpired in one of our providers, on a £40 million budget, we are only overspending by less than 0.01%. So in terms of our planning for growth, you know, we do have a sound track record. There are some unexpected issues that have arisen in year, that SDEC issue that Hayley's referenced, and this acceleration of waiting times with some of the underlying bed days issues in NHS England. So we are very much learning from this year in terms of our tactical commissioning choices and planning for next year. And as Hayley has referenced, we'll be bringing that for discussion to the board in February, and then it'll form our plan. We are really looking at our controls and levers as well, and also taking some advice just to make sure we're learning from others, that we are maximising all of those opportunities, particularly in the English system. So just wanted to assure the board on all of those points.
Thank you, Nick. Kirsty, anything you want to say in response?
No, I'm greatly heartened that all of these issues seem to are being addressed. I think, you know, collectively, all of these points will lead us to a more sustainable situation as we move forward. So I'm grateful to colleagues. Thank you.
Thank you. Steve Elliott, please.
Thank you, and thank you, Hayley, for that for the report and that verbal update. I think both yourself and Carl have stressed how important the board take our financial responsibilities very seriously. But I think you've done well to articulate the reasons for the recommendation, and particularly based on the low delivery confidence. So on that basis, I'm also supporting the recommendation. I was going to raise it in the finance paper, but as you've raised it now, Hayley, I would just want to echo the acknowledgement you raised around the significant amount of achievement in delivering the savings programme of 9.9 million this year, which is the highest, I believe, that Powys has delivered for a long time. And I think that achievement shouldn't be lost in the within the significant financial concern situation we find ourselves. So that's good. I was just going to raise one issue or one question really around the work on agency, just to ask whether any of the work in terms of enhanced scrutiny approval has had any concerns clinically, and also just to get your assessment of confidence in terms of delivering the Welsh Government targets next year in terms of reduction in agency and no off-contract expenditure. Thanks.
Thank you, Steve. Really important points. If it's okay, I'll ask Deb and perhaps one of the clinical directors to respond first of all, and then happy to come in with my perspective at the end, if that's okay. Thanks.
Yeah, thanks, Steve. The new risk assessment process is in place. It is being tested and retested just to make sure that everybody understands. I think it's probably too soon to say the extent to which we'll see some traction on that. Probably a conversation to have at our next meeting. But I think the messaging that we've put out about that additional level of scrutiny will require individuals who might have previously looked to book agency to think slightly differently about their need and whether there's a way of potentially cross-covering. The other thing it will do, of course, is in requiring at that level of scrutiny, it requires people to think through much earlier about their roster requirements and therefore more actively looking at bank options, should they be an option. I think your question around the 30% agency reduction and the elimination of certain categories of healthcare support workers by September is an area that I know Elaine and others are looking at under the variable pay group. It may require us to think very carefully about how some of our wards and therefore our beds are configured if we are going to be able to meet that reduction at that point. But we've got time between now and September to do that workforce planning. And you might recall that in the paper that we had on the 10th of January, we also talked about the potential need to use the organisation change policy and the deployment of staff. So as the recruitment, I'm saying in inverted commas, freeze, because I know there are posts out for recruitment because they've been considered to be critical, but as the recruitment tightening and the agency reduction takes hold, and I think it requires us to think through all options really of being able to meet those targets and continue to deliver services. I hope that helps. I can see Claire's got a hand up as well.
Thank you, Deb. Please come in, Claire.
Yeah, diolch, thank you. Steve, you mentioned there about clinical risk. Clearly, we will monitor that through our usual processes of monitoring concerns, incidents, etc. I do want to give assurance that we use a programme called Safe Care that monitors security and activity on the wards. And of course, the risk assessment focus is as much about scrutiny of the request for agency or additional staffing as it is for being able to make an assessment of the clinical need in the clinical area. So I just want to assure the board members that that balance between scrutiny of the requirement for additional staffing and the assessment of clinical need in a ward area is absolutely the balance of the risk assessment. Thank you.
And Kate, our medical director, also wants to comment. So please do, Kate.
Yeah, thank you. Just important also to highlight that we do have medical locum use as well. That is almost entirely based on long-term vacancy. And so it has been challenging. However, there is active work we will always scrutinise and we're continuing to do that. And we have had some success in recruitment. So we've had 2 overseas doctors start just very recently, or one started, one due to start, and we're undertaking further recruitment. So I anticipate that locum spend will start to reduce very quickly now, but obviously watching it very, very carefully as well.
Thank you all. Anything in addition from you, Hayley?
It was just thank you to colleagues for coming in. I think it's important that you hear from us all as an executive team. The Welsh Government target of 30% next year has been set for across the whole of Wales, and I think we've got local actions which we describe here. But I think Deb's point around how we organise ourselves around this will be important factor in being able to make that achievable. But I also wanted to just reference how we're working more nationally on some of these issues as well, wanting to reduce our reliance on agency and locums is a key area of work nationally, and clearly we're learning from each other as well during this process. But it's not going to be straightforward, and it's not going to be easy to hit that target without us looking at how we organise ourselves differently in order to do that. And I just didn't want to give you false assurance that it's going to be easy to be done next year, but that is what we're planning. We've been asked to plan against, and that will be part of the options that we'll be putting forward for the board to consider in the March plan.
Steve, anything from you in response?
No, thank you for the responses. Thank you.
We turn to Simon.
Thank you, Chair, and thank you, Hayley and colleagues, for the reports you brought today and for clearly the significant work that's taken place since we last met. I was particularly glad, Hayley, that you drew out thanks to our colleagues in this health board and to those in partner health boards across the border, which is incredibly important to the delivery of care for the population of Powys. There was a number of things, particularly in the integrated impact assessment, that I wanted to kind of draw out and just ask some questions around, because it really, for me, spells out the tension we have between differing statutory legal duties around caring for the population of Powys as against delivering a balanced budget. The thing that really struck me was some of the notes in here around the likely, almost certainty, of there being provider challenge from English providers should we pursue the decision. So I wanted to just ask a little bit more about what the projected consequence of that would have been in terms of both cost, but also time and resource of the executive board to respond to those kind of challenges, and to check an assumption that we wouldn't be able to take forward the implementation of that decision whilst in dispute, if that's the position we were in. It struck me that would have a certain impact. How significant would that impact be on the projected cost savings? And also that actually, what do we assess as the likelihood of the movement of cost to another part of the system? And again, that having a detrimental impact on that total kind of cost saving figure. The then other key thing I drew out from the integrated impact assessment was the almost certainty, I think, that if we were to pursue this decision, we would find ourselves in escalated interventions across at least one or a number of the other key domains with Welsh Government. So I'd just be interested to understand if my assessment and assumption there is correct. And those two things really, for me, combine to lead me to a very clear view that this is the correct outcome and recommendation from the executive board, and something I am comfortable and confident in supporting. Thank you, Chair.
Thank
Hayley,
you, Simon.
please respond.
Yeah, thank you, Simon. And Pete or Nicola, you may want to come in as well on this point. So this is part of the issue about taking a decision in year, Simon, versus agreeing up front an approach with our providers. And clearly providers have the right to challenge if we make a decision that is different to their assumptions at the beginning of the financial year. And that is not a good place to be in, and that would have delayed our ability to implement the change if indeed we found ourselves in in a position where providers were challenging and disputing our decision. What we want to do is avoid that going into next financial year. So upfront planning and discussion and agreement, rather than needing to further refine our assumptions within year. And I think the impact of that would mean how we sustain our excellent strategic relationships with our partners from the outset, to avoid neither the provider or ourselves would want to be in dispute in NHS Wales or in NHS England. And it is really, really important that we try and avoid that. So it's therefore about how do we negotiate and agree an agreeable approach to both provider and an affordable approach from us as a commissioner. And clearly that is part of the work that Nicola and the team will be undertaking in detail in discussing our draft commissioning intentions going into next year. The question around the likelihood of cost movement to other areas is really difficult, Simon, to assess. And again, we talked about areas like it may result in different prescribing practice, different requests going back to primary care for ongoing support, etc. We haven't been able to put a financial value on that, Simon. But we do know that could be potentially quite substantial in terms of increased patient contacts with particularly primary care. So but we haven't been able to fully financially assess that. And I think in terms of your point around the impact on other domains, I know in our last board meeting Jen asked a similar question, and clearly I can't guess the outcome of the escalation process that involves Welsh Government regulators, etc. But one of the key issues, and this is where the balance comes in, is how do we balance making the adequate financial improvement without actually impacting on performance, access, patients and other domains which we're assessed against as well. And the triangulation of that information across all of the domains is what the escalation framework is based on. So I think, we would still, though, in this case, be meeting our Welsh waiting times targets. So, I don't think it would be in the performance and access element, but we might be quite potentially inundated with a large number of concerns and complaints, and therefore we might find other factors like our ability to respond to some of those elements being compromised during the last quarter of the year if we were to choose to take the decision to implement it. But I can see others may want to come in. Carl, Nicola, I can see he's got a hand up. Thanks.
Nicola?
Sorry, Carl, did you say Nicola then?
Yes, please
Oh,
come in.
sorry, I couldn't quite hear you. Diolch. Just to add a little bit there, Simon, so I would say that our three main English providers have been really open and constructive in the discussion that we've had with them. As professional managers in the public sector body, they've also been acknowledged how difficult these conversations and decisions are for us, both as executive officers and as a board. So some of the pressures are not unknown in the English system as well. So I think the paper does reflect that the elective recovery fund in NHSE that has been capped. So an indication that maybe the system in England is running hot for some of the decisions they need to make financially as well. I think our providers, what they are asking for is some certainty and at least some indications, which we call our commission intentions, on which to plan for next year. Quite rightly, we would be asking for that in their position. So I think after the conversation today, we will be feeding back to them, and some of the considerations we'll be having as an exec and board in February. We'll be starting those conversations with them next week, and then working with them on that on their planning for next year. around some of those choices that Hayley referenced earlier in the discussion on the paper.
Thank you, Nick. Simon, any further comment from you?
Just to say thank you very much, and it's really encouraging to hear that we've got a kind of mature relationship with the English providers, and it underlines for me just how critical that strategic relationship is for the delivery of care to the population of Powys, and that's really not something we should be putting at risk. So the decision we're being asked today to take seems to me to be one that can underline the importance of that strategic relationship and set up exactly the conversations that now need to take place for planning and managed approach in the plans we're developing in current time. So thank you.
Thank you, Simon. We've still got some colleagues that want to contribute to this agenda item. I'm happy to take for it to take up more of our time. It's a very key issue in which there is significant interest. But I'm going to ask, please, that we go to Chris Walsh, and then I'll invite Katie Blackburn, the Regional Director of Llais, the Citizens' Voice body, also to comment. We will then take some responses to those comments before going to Ronnie and Mick. So please come in, Chris.
Yes, thank you, Chair, and thank you, Hayley, again for setting out the context. I just want to repeat a point, if I may, about the savings that Stephen mentioned about. I think that is significant and it shouldn't be lost, and that's hence why I made it as a point of my comments now on and congratulations to the team doing that. I think there is an opportunity now, and I also welcome the shift potentially towards a primary care led more model in how we're doing prevention rather than just a treatment aspect to it. I think that is the way forward. Being proactive helps us. But in doing so, is there, and I'm looking for the assurance that we have the skill sets which are going to be slightly different to be able to deliver that new emphasis around that agenda? And do we have the training provision to back that up? So it's about whole system, looking at it across. And is there then any opportunity to work in partnership with the local authority regarding that same agenda as well? Because they're looking at how they set up the Sustainable Powys agenda, which I know we've been participants in. I just then want to come back to page 4 of the report, and it mentions there about the roster scrutiny and efficiency measures. A couple of things in here that I just wanted to get some further clarification on. There is an operational group that's stood up to review standardization of shift times. How recent is that, and what was the variance there before around the shift time legacy? And then it mentions then about the handover time has been reduced. Does that expose us to any clinical risks with that? And were there any costs being incurred with handover time? Because I thought that would have been done within the shift time. So I don't fully understand that element, and that would be helpful to know. And then the variation in pay, one of the big drivers towards our costs is around agency. If that is so, the way that we'll counteract that in some ways is by recruiting. And I know that we have some vacancies within the health board. So therefore, by doing a freeze, does that impact on our ability to be able to get to a higher level staffing so that we don't then rely on agency? And I'm just making sure I've not misinterpreted that we're not going to be doing what we should be doing, which is recruiting to our full establishment, which would then rule out the necessity for agency in the numbers that we've currently got. And I'll stop there, Chair.
Thank you, Chris. I'm going to go to Katie. Lots of questions there, Chris. Lots of detail, and it may be that some of that detail, can be shared outside the meeting and so on.
Sure.
However, we will come back to those. So, Katie, please come in.
Thank you, Chair. Just to say, recognising the considerable financial challenges facing the Health Board and the likelihood of needing to take difficult decisions, I just want to, to provide assurance that we will continue to share as Llais with you what we've heard from the communities of Powys to help inform your discussions and decisions. And I suppose just to reiterate and to really sort of strengthen the need for continuous engagement and communication with individuals and communities going forward as continuous engagement and communication going forward. Thank you, Chair.
Thank you. Hayley, please come in or bring in colleagues in response to Chris and indeed to Katie's important points.
I mean, just the last point from Katie, how do we work together with the public, with the population of Powys on these matters is critical to our ability to putting forward sustainability around our services and how we commission as well. So completely agree, and there will be strong commitment and action around a continuous engagement with regard to these issues as we move forward. I think that Chris's points have a lot in it, but I was just wondering, Chris, just from a whole system point of view, the public service in Powys, we need to work in partnership, and the commitment of how we work together with the third sector, the local authority and other colleagues is absolutely critical to being able to continue to deliver sustainable services. And I would like Mez to come in, if that's okay, recognising that Mez has led whole system approach to a number of key pieces of work and is expert in the space of that shift towards prevention, could comment in on the skill set and the shift. But I think we're from a very strong base because we have got such a strong foundation of primary community mental health services in the county, and the approach. And then just to give a bit of pre-warning to Claire to come in on the points raised regarding roster scrutiny, efficiency and the impact of the freeze, if that's okay. Thanks.
Okay, thank you, Hayley, and thanks, Chris. Important sort of point really there. As you mentioned, working in partnership around prevention and that early intervention is absolutely crucial element there. And whole systems approach as an example around weight management, where we identified that we need to do work around early years, and particularly the first sort of 5 years there, where we knew we had high rates of obesity in children and weight management. So we have been doing systems approach around that, and I'd advocate that approach going forward around sort of prevention and that shift sort of left element. Also crucially, just to highlight really the great work that is going on in primary care around managing chronic conditions, and also we have specialist nurses in the health board as well. So key would be then to increase capacity and also standardising messages across our partners to make sure that we galvanise around those areas of need and prioritisation going forward. I think I'm handing over to Claire now, I think.
Yes, thank you, Mez. So in relation to your question around roster scrutiny and efficiency. So the first thing I want to say, and I will pick this up later in the board actually on the agenda in relation to nurse staffing, is that our roster levels are set every year and agreed by me as the designated person under the Nurse Staffing Act. The rosters are scrutinised and assessed against those agreed staffing levels. And in terms of recruitment and targeting our recruitment, it is important to say that our internationally educated nurses that we have recruited over the last 2 years and continue to have huge success with are being targeted into those areas where we have vacancies in relation to our registered nursing numbers. We also are, working with our nursing colleagues across the organisation to look at where we can absolutely be even more efficient in the way in which we deploy both our registered nursing staff and our healthcare support workers staff within the ward areas that we have, and really challenging ourselves to be creative in terms of how we can maximise our efficiencies in that space. But I do want to give assurance that we have agreed registered nurse and healthcare support worker staffing levels across the organisation. Those are reviewed annually, and that will be picked up later in the agenda, Carl, when I present the annual nurse staffing report.
Thank you very much, Claire. I'll just pause in case Chris wants to respond in any way. Otherwise,
no, I'm fine with those responses, Chair.
Thank you very much, Chris. Finally, we'll invite Ronnie and Mick to contribute. We will have a response to their contributions, and then I will move to the recommendation on this agenda item. Thank you, Ronnie.
Thank you, Carl. Hayley, I think it's important that I say, I think you've been very clear in your presentation on this, and the team have been very clear in their paper, and I support the recommendation. I suppose what I was thinking about was the Lord Darcy report, and I know that applies to England, but actually I think there are general principles that apply throughout the rest of the UK. And from my perspective, what I'm conscious of is his emphasis on the first step to rebuilding public trust and confidence in the NHS is to be completely honest about where it stands. And that's what I think you have done and what you continue to do in respect of Powys. So I just wanted to acknowledge that point. I'm pleased to hear from Kate that there's been progress on the medical locum situation, but I do have a question either for you, Hayley, or for Deborah, and that's on the issue of vacancy controls. And I suppose I come to it from a slightly different position than Chris. I looked at the number of posts that were being advertised over the weekend, and to me it seemed there were still quite a lot as a general observation. But of course, I can't see posts that have been slowed down because they've been slowed down, and I can't see posts that have been frozen because they're not in that advertisement process. So I'm just seeking reassurance that the posts that are there and are advertised have been subject to a very robust process. Thank you.
Thank you, Ronnie. And so we go. Hayley, can we take Mick's comment as well, and then we'll come back to you and colleagues. Thank you, Mick.
Chair. I have an observation. I did have a question actually, which is around, learning the lessons from this year's experience, and how we can use that to influence the approach going forward in future years. But I think a combination of Hayley's opening comments and the detailed response to Kirsty's question covered that. So in the interest of time, I won't repeat it. I will just very briefly, if I may, offer my observation. This is a really difficult decision, contentious decision, and it has potentially difficult consequences. So, and I think it's important that decisions like this are collectively owned by the board and that ownership is visible. So I just wanted to add my support really to the recommendation not to proceed with adjusting the current plans for commissioning elective care in year. I think the impact assessment is really clear. The potential impact in terms of service quality, The detriment that deferring treatment will cause to patients feels disproportionate to the level of savings which might be achieved. And there does appear to be some uncertainty around the deliverability of those savings. So, for me, it will have a minimal impact on the overall outturn. I think we're simply deferring the problem into next financial year if we went down that route. The treatment will have to be paid for somewhere. Next financial year looks more difficult than the current one. And there is a significant potential loss of opportunity cost and administration costs that we can't recover. So I just wanted to register my support for the recommendations as they're written.
Thank you, Mick. Really helpful. So Hayley, any certainly response to Ronnie and Mick's observations, and particularly Ronnie's question, and any final reflections from you?
Yeah, thank you. So I note most of those comments, agree with many of those comments that have been made. I think that Ronnie's point around Lord Darcy, I know that the Ministerial Advisory Group is currently undertaking a national review of a number of areas to look at opportunities about how we can work differently to improve efficiency and productivity, taking learning from the whole of the UK, but particularly in discussions with all trusts and health boards across Wales. So I think that some of Lord Darcy's report and findings will probably form part of the reflections that we'll see through the Ministerial Advisory Group. And I'm really grateful to Ronnie for raising the issue around public trust and confidence. I appreciate it is difficult, but I think it is important that we set out really clearly the challenges that we're facing. And talking back to Katie's point, that we have the right approach in engaging and communicating with the public around the choices that we will face as a whole public sector in relation to future models of care and decisions around, for example, commissioning. I would ask Ronnie for Deb to come in on the point that you raise around your assessment and assurance that you're seeking that we have got the vacancy controls in place based on reviewing our number of vacancies that are currently being advertised. And then just final point around the collective board ownership that Mick has raised. I felt it was very important today that as an executive team we make a clear recommendation, but recognising the implications of the next steps of not taking a decision around our financial position and the need to have those ongoing discussions with Welsh Government. It is really important that we're collectively supportive of the whole board of the decision being taken. Thanks.
So thanks for the question, Ronnie. I understand the points that you're making. Of the 156 posts that have been reviewed since we put the additional scrutiny in place, 44 slowed down, 8 have been frozen, which is a cost avoidance of 150,000 per month of not recruiting to those posts. The executives overseeing each of those vacancies have made those decisions against preset criteria that we put in place, and their decisions are then further overseen by myself and Pete. It's not possible not to have any recruitment. And if we look at the posts that are currently live on our website, then they are kind of clinical, professional or essential services. And particularly, one of the factors that is considered is where in freezing a post, we would then need to require agency cover. And I hear the point that Chris was making about the cost of agency cover. So this is making sure that we are not having unintended consequences by freezing a post and then having to put agency cover in order to deliver a service. What will be important for us going forward is to continue to review that criteria and then make decisions as part of our development of our plan and the conversations that we will have in the coming weeks about how we might need to prioritise services, how we might need to therefore prioritise the recruitment of those services and what we do for all other services that we run. But that's clearly not a question for today, because we need to do some of that work. But I guess just in summary, there is enhanced scrutiny overseen by all of the exec committee and various forums, and we'll continue to review that as we go forward.
Thank you, Deborah.
Thank you. Hayley, should we move now to the recommendation, or do you have any final comments? No.
No final comments, thanks.
Okay, well, thank you, Hayley, to you and exec colleagues. I certainly echo the observations of other independent member colleagues in appreciating the clarity and the substance of the information that you've brought to us today. Mixed comment about board ownership, certainly I also would want to underline. These are difficult decisions, and as Hayley has said, it is about owning the immediate decisions, but also their implications, both for this financial year and indeed some of the issues that we will need to give serious consideration to next year and beyond. Now, a number of colleagues have already indicated that they support the recommendations. For clarity, it is a long composite recommendation, but in the interest of clarity, I will read it out and then I will invite people to support it or otherwise. So the recommendation is that we note the update on the delivery of variable pay reductions through reduced use of agency and locums and the vacancy freeze. That we consider the more detailed assessment of the options for further action following discussion with NHS England providers requesting the revision of elective activity during quarter four in 2024-25, noting the associated financial impacts and risks. We also consider the final integrated impact assessment, which has been prepared to help inform this decision. We approve that the Health Board does not implement any changes to elective activity in quarter four of 2024-25. We note that further work is required with providers to review the approach to commissioning activity in 25-26 within available resources. And we also note that ongoing dialogue will take place with Welsh Government, advising of the board's decisions and requesting ongoing discussion on next steps and strategic cash support for the remainder of 24-25. Colleagues, would you please indicate if you don't support that recommendation? So that is supported unanimously. Thank you very much indeed. We turn now to other items on our agenda, and firstly to the anti-racism plan. We are running over time by some half an hour or so. However, particularly the last item and indeed previous discussions, I feel were so important that they just needed the time that they needed, and that we shouldn't have been straitjacketed, as it were, by any indicative times. So I think that was the right thing to do. But it may be that some of the other items on our agenda can be dealt with a little more succinctly, important as they are. But we turn now to Deb, and who is going to introduce to us the item 3.3 on our anti-racism plan.
Diolch, Carl. I'll take the report as read, but just pull out a bit of an overall summary for colleagues. So in 2022, the Welsh Government published their anti-racism plan. That was then updated in 2024. Board will recall that in 2023 we brought our first anti-racism plan, and as a result now of a revised plan from Welsh Government, we've revised our local anti-racism plan, which is in the papers today for board consideration. We've also incorporated within our plan the results of the Workforce Race Equality Standard Report that we received in July 2024, and similar to other NHS Wales organisations, it set out some areas of inequality and areas that we needed to consider. Just to summarise, that was around ethnic minority board membership, ethnic minority staff in senior grades, poor declarations of ethnicity across some senior staff, and ethnic minorities being shortlisted into posts. Just to reassure, work is already underway on those RES report actions, and we have a further follow-up meeting with the lead from Welsh Government next week. By way of further reassurance, the revised action plan in your papers has been shared and tested through a consultative approach with our minority ethnic staff network and through the Workforce Policy Review Group, which includes important voices and trade union
We seem to have continuing connection difficulties with Deb, and I think we may have lost her altogether. Hayley, we got Deb's comments to the point that we lost her. Can you or any other of your colleagues complete the introduction to this paper?
I'm not quite sure. I haven't got the detail of her introduction, so apologies, Carl. But I think from my perspective, my suggestion is we open it up for discussion, and then hopefully Deb will be able to rejoin us, because I haven't seen her presentation, but clearly I think we've all read the report. I think we should open it up for discussion, if that's okay.
Absolutely fine. Does anyone want to come in with a contribution, question, observation in response to the anti-racism plan? Can't see anyone. Of course, it was given detailed consideration at the executive committee, Hayley. Just for my own interest, really, on page 2 of the covering report, mention is made of encouraging the establishment of a minoritized ethnic staff network. I just wondered whether has that been taken up? Is it or not? It is an encouragement. It's not a requirement. But just wondered whether there has been any response to that. Claire, would you like to come in?
Yeah, I can come in on Deb's behalf for that one, because that started whilst this was still part of my portfolio, and we did set up a network within Powys. There wasn't a huge uptake, but what we have done is also set up networks with neighbouring health boards, so if people are more local to those ones, they can join those, and those tend to be bigger groups. So that has been well established, and the team work to publicise local events that are going on that people can access.
Thank you. Ronnie, please come in.
Thank you, Carl. I just wanted to say that in terms of brag status, most of this is actually green or blue, and I think that's a considerable achievement. But there are two that are shown as ongoing. The one that I had a question about was on page 17 of 17, and the last one, time to change Wales will develop and deliver an anti-racist mental health anti-stigma campaign. And that's going to be delivered, the responsible department is shown as mental health. Looking at the progress, I wasn't really clear as to where it sat now and what was the timescale for some sort of delivery on that. And I wondered if anyone could provide any clarification around that for me, please. Thank you.
Thank you, Ronnie. Does anyone have that information, Hayley?
Ronnie, I'm not sure. I would suggest, I don't think, Elaine, you don't know. Okay. Would you mind if we pick it up as an action to provide further assurance to the board? I know that they've been doing scoping work on this, but in terms of the detailed question that you asked, Ronnie, can I suggest that we pick that up and share for the next meeting? Is that okay?
Of course, Hilly, this is an issue I feel strongly about, and that's why I reference it. Thank you.
Mick, please.
Thanks, Chair. As I read through the report, it's clearly very comprehensive, and as Ronnie says, there's lots of activity and action and progress reported there. But other than the odd kind of percentage or figure, there wasn't a great deal in terms of kind of measurable, quantifiable objectives. It's difficult to kind of see what the baseline is that we're kind of working from, and therefore, it's very, very difficult going forward then to understand what the outcomes of this work are. And I appreciate this may not be the place for that kind of information, but would just like some assurance that somewhere behind this sits a kind of smart action plan, for want of a better word, and that if that's not the case, then whether there are plans incrementally to kind of develop in that direction going forward.
Yeah, thank you, Mick. I know that one of the issues that I think this is such an important piece of work that we should schedule some time in the Workforce Committee to go through the detail underpinning these questions. I know the measurement and baseline, there's some work that's been undertaken, and I know that that's something that nationally also there's some discussions about how we can strengthen that. But in terms of giving that further assurance, may I suggest that we pick up these questions and bring them into the Workforce and Culture Committee? Would that be okay?
You okay, Mick?
Yeah, absolutely. Thank you.
Simon.
Thank you, Chair. I was going to just pick up on Ronnie's first point and just suggest that the other two actions that have yet to have a target date on, if we could come back to that as well, perhaps outside the meeting, that would be helpful. And I was going to raise the point Mick's just raised around target measures. So great that that's been raised and addressed and can go into the Workforce Committee. Thank you.
Thank you, Simon. So just to confirm, unfortunately, we have lost the connection to Deb, but as Hayley has helpfully suggested, we won't lose sight of the questions and issues that have been raised, particularly the dates and Mick's comment about what's the baseline data, what are the measurables that are associated with this plan, and that those actions, as it were, will be the subject of discussion at our Workforce and Culture Committee, which we will then hear about in the reports from that committee. Given that, we are asked to approve the new anti-racism plan. Again, does anyone want to indicate that they don't approve the plan? That is therefore approved unanimously, which takes us to item 3.4 on our agenda, the report from our Director of Corporate Governance, Helen, and over to you, Helen.
Diolch, Carl. Thank you very much. A relatively light report from me for this meeting, just 3 areas to cover briefly. The first part of the report just summarises our board activity. You've already referred, Carl, that we had an additional in-public meeting on the 10th of January. We've had no other in-committee meetings since our last scheduled one in November, which the public are aware of. And we've continued our board development schedule as planned in both December and January. The second item is in relation to the application of our common seal. We're required to report those. There's a set of procedures that we also follow in line with our rules and standing orders. The common seal has been applied on 2 occasions with both you as chair and Hayley as chief executive's authority. And then the third item, just requesting the board's approval. You'll be aware, board members, you have previously, I think it was in March of last year, 2024, you've previously agreed the governance framework, including the standing orders and standing financial instructions for the NHS Wales Joint Commissioning Committee. The JCC is a joint committee of all 7 health boards in Wales. And in accordance with that governance framework, any changes require the consideration and approval of all 7 health boards. So the item in front of us today is a relatively minor revision to the 2 JCC subcommittee terms of reference. We knew at the time when they were presented last year that they were subject to further review. The change is with the full endorsement of the Joint Commissioning Committee itself, and it's essentially to make Health Board Chief Exec or a Health Board Chief Executive member a full member of the subcommittees as opposed to an observing member. That's for the Performance and Finance Committee and the Quality and Safety Outcomes Committee of the JCC. So Carl's seeking approval of that item today if members are content, but very happy to take any questions. Thank you.
Thank you, Helen. Are there any questions for Helen or any comments in response to her report? No, so we'll move to the recommendation that we receive the report of the Director of Corporate Governance, that we ratify the application of the Common Seal applied on 2 occasions. We take assurance that the action was taken in accordance with Section 9 of our standing orders, and that we approve the updated terms of reference for the JCC Quality, Safety and Outcomes Subcommittee and the JCC Planning, Performance and Finance Subcommittee. Again, would anyone like to indicate that they don't support or want to comment on their support of that recommendation? No, so that too is supported unanimously. And so we come to the final matter on our agenda for approval, which are the minutes of our meeting held on the 27th of November. We also have the minutes of our extraordinary meeting held on the 10th of January. I'll take them separately for approval. Firstly, 27th of November, for accuracy, are there any corrections, amendments that anyone would like to suggest? No, so those are approved as a correct record, and equally for the minutes from the 10th of January. Again, does anybody want to suggest any changes? And so they too are approved as a correct record. Thank you very much. We will be breaking for lunch. I might suggest at that juncture that we have a bit of a shorter lunch break than is planned, so that we might get back on track a little bit more in terms of our timing today. But I am going to suggest that we do take another 5-minute break at this juncture before we turn our attentions to item 4, items for board assurance. I don't know why my brain goes into meltdown when I look at clocks and timetables, but I think perhaps even I can say we'll come back at 12:25. Thank you. Well, croeso nôl. Welcome back. I think we're okay to reconvene our meeting. And so we turn our attention to item 4 on our agenda, and initially to our financial performance report for month 9. And Pete will introduce us to this agenda item. Thank you, Pete.
Yeah, thank you, Carl. Thank you, Chair. Clearly, this item relates to the conversation we had around item 3.2. I'll go through the key highlighted issues from the financial report, which is in the usual format, and then we can pick up any questions and queries. So this is the financial report as of month 9. Against our revenue position, we have a current actual position of £18.3 million variance against our planned deficit plan of 11.8 million, giving us a 6.5 million revenue variance against our deficit plan. As a reminder, we continue to monitor ourselves against our deficit plan, which has been amended to 15.8 million on the back of the additional funding we received in month 8. In terms of our capital position, we have a total capital spend of 2.6 million against a capital resource limit of 13.1 million. It's worth noting against this profile that we received circa 9 million of additional capital funding in October, and a lot of those actions in relation to that funding are profiled into the final quarter of this year. This is closely monitored to make sure that we deliver within the funding as allocated. As I move through the report, we've again touched on a number of these areas. Our key cost drivers against our financial position are in relation to our commission services that we discussed earlier, in relation to continuing healthcare, and in relation to agency, again, as referenced in the earlier conversations. I think it's worth noting from the report that we have seen a reduction in our variable pay in month 9. That, again, is linked to some of the actions and progress that has been made. We continue to monitor that closely, and any additional benefit helps us to reduce and deliver against those mitigating actions needed to improve our financial position. Again, we included a long discussion around the action being taken in terms of delayed transfers of care. We continue to report the financial implications of those delays on the system. Clearly, it's a wicked system issue. It's an area we work closely with our local authority partners on, and something that we've seen some progress, and I'm hoping that in our next month's reporting, we will see the financial benefit of some of those actions, some of those reductions in length of stay as were described. I think the key thing then really to summarise before we open up for any questions is a reminder that against our current deficit plan, 15.8 million, we identified the need for circa 9.4 million mitigating actions to deliver that position. We've had an update in terms of the areas around vacancy freeze, agency, and other action areas where we continue to focus and push to deliver as much financial benefit as possible. Noting the board decision around the English activity, we will reassess the likely position and forecast, and this will trigger a revised forecast to be reported out on the 10 position, and the action as Hayley highlighted around the need for an accountable officer letter to go into Welsh Government. So what this does mean is that we need the whole health board to maintain that focus on its current expenditure and run rates, to reduce that wherever possible, and to keep that discipline around all areas of spend, making sure that we're delivering value for money wherever possible. So I think I'll pause there, Carl, and happy to take any questions and open up for wider discussion.
Thank you, Pete. Are there any questions, comments for Pete on the financial performance month 9 report? And so let me go initially to Ronnie, please.
Thank you, Carl, and thank you, Pete. As always, this is very clearly presented. I just did want to touch base with you on the agency expenditure of 0.4 million, which I think you said is the lowest this year, that it has been in the lowest in respect of last year too. And I suppose what that sparked for me is a question: couldn't we have done some of that before? And so what is different now? And my other question, perhaps predictably, is in relation to the issue of capital funding. It seems to me that we've got an awful lot to spend, a lot of activity in the remaining few months of this financial year, and are you entirely confident that we can achieve it? Thank you.
Pete?
Yeah, thanks, Ronnie. I think the question around the action and controls around agency we probably covered early on in our discussion. So there's a myriad of factors which influence that in terms of the recruitment progress, the increased focus and all those things which are helping to contribute to that. You're right, it's pleasing to note some of that benefit in month, and we will monitor the expected delivery against those mitigating actions as targeted in the paper presented in 3.2. So we had a total opportunity around agency spend of circa 3 million for the last 3 months of the year, with a current assessment of delivery of circa 500,000, which is under constant review. So we'll update that, and that will inform our final forecast. In relation to capital, as I alluded to in my overview, we did receive just under £9 million worth of additional capital resource in October. That was on the back of actions and movements in month against potential funding available. That has been profiled into Q4, so is as expected. I do know that we've got £3 million worth of medical and dental equipment which has been ordered, with various confirmed delivery dates from now until the end of the year. And there's a significant amount of funding in relation to the Llandrindon scheme, which is on progress and on target to be completed by the end of the financial year. Also worth referencing as well, we had 3.6 million funding in relation to decarbonisation and refit. And again, we've got similar assurance around the delivery and the profile of that spend. So at this point, noting the spend profile, noting the actions, it's an area that we are expecting to deliver against.
Thank you.
Steve, please.
Thanks, Pete. I was going to raise the same issue around capital as Ronnie, so thanks for the response to that. And also thank you for updating the process regarding revising the forecast, because clearly we're unlikely now to achieve the deficit plan, so confirming that'll be done in month 10. I was just going to ask one question relating to slide 7, the prescribing slide, and the graph seems to indicate quite a significant uptick in prescribed units just at the end of the graph in terms of the sort of during last calendar year. Is there any reason for that, and is that likely to feed into increased costs, which puts further risk to our plan? Thanks.
Yeah. So in terms of that element there, I will have to get some further information. But what we do is every month, working the finance team and our pharmacy team, we review our current position, we review the trends, and that's always informing our forecast position. And those latest figures on the table in terms of the budget against forecast position are as up to date as they can be. And I will just bring reference to the fact that our medicines management team are forecast to deliver £2.2 million worth of savings against an initial target of 1.1 million. So it is an area of significant action and financial benefit and success. I don't know. I'm not sure if Kate will may want to.
Okay, please come in, Kate.
Yeah, thank you. So in terms of the prescribing and the volume of prescribing, then it is complicated, as Pete says, and the medicines team has a really firm grip on monitoring and benchmarking, really, and feeding back. There are complexities, and it does fluctuate. So yes, the graph has gone up. I think that's being looked at. There is no clear pattern to that. We know that as we repatriate more patients back into Powys and we do try and deliver more care, inevitably our prescribing units probably will go up. But I think I am always really cautious about drawing conclusions from a single trend, because we know with medicines it does go up and down, as do the costs of medicine. So I think it is quite complicated, but just to assure there is grip and it's being constantly monitored.
You content, Steve?
Yeah, that's fine. Thank you.
So we go to Mick.
Thanks, Chair. Peter, I've said this before, but I think just important to re-emphasise it in the context of the conversation we had earlier. You know, we might not like what it says in the finance report, but it's very clear. It's very easy to understand for a non-finance person. It very clearly sets out what's driving our cost pressures, and, you know, more importantly, what's being done to seek to address them. And from that, it kind of indicates where some of the long-term solutions might lie. I was interested to note, reading the de-escalation criteria for the targeted intervention process, that one of the key measures is to understand what's driving the underlying budgetary challenges. So, you know, it's a reassuring position to start from, maybe not from a financial perspective, but certainly from a governance perspective, that we have this clarity. I just wanted to re-emphasise that. I just had a question on page 276, which I think is page 5 of your report. Mentioned several times in this report and in others that Shrewsbury and Telford hospitals are unable to report activity. Apologies if I've missed it, but, you know, why is that? And what are the implications? Is there any risk to our financial projections? Could they worsen, or, you know, could they improve even?
So thanks for the comments, Mick. And in terms of the Shrewsbury and Telford position, there's no risk to the financial position, because we've agreed a sort of a block approach with the provider so that we de-risk both of our positions. Nick probably would be best placed to come in and comment on their data issues, which has meant that activity information is not available as it normally would be. So if I ask Nick just to comment on that, if that's okay.
Yeah, thank you for the question. Thanks, Pete. So they have had serious problems with their data warehouse and data processing, which they've transparently declared to us and to the English commissioners as well, and we're fully aware of that. I think rather than the financial consequence, it may affect the ability to plan, and it's affected the ability to plan and performance manage more in year. As Pete's described from a financial point of view, it's actually given us stability both sides, because we're able to put that block contract in place. Their plan is that they will be able to report by the end of the year, and will be able to do that sustainably from May, and that's still on track at the moment.
Thank you.
And so Simon.
Thanks, Chair. Just a point of detail on page 7 of the report, just to clarify my understanding. You've got in there a forecast underspend of 1.8 million, but also then in the box in the bottom right hand corner, you talk about schemes forecast to deliver 2.2 million savings. Are these the same figures, and in which case is it 1.8 down from 2.2?
Sorry, Simon, I missed the first part of what you said. Sorry, I missed the first bit.
On page 7 of the report, your
Okay,
slide deck, there's references to a forecast underspend of 1.8 million on the 24-25 budget year, but then later in the box around on the bottom right hand corner, you talk about 2.2 million. I just wondered, the same figures, or are they made up differently?
Yeah, they're slightly different things. So it's a 1.8 million underspend in total against their budget allocation, and then that's a delivery of savings against their savings target. So they're two separate things which clearly relate. Yeah, thank you.
Thank you, Simon. I can't see anyone else wanting to come in. Any final comments or observations from you, Pete?
No, I don't think so. Thank you, Chair.
Okay. So we'll move to the recommendation. In light of our discussions earlier and the item on our annual plan for this year, we do need to revise the last bullet point of the recommendation for this agenda item. And so my suggestion is that instead of the bullet point that is in your papers, we replace it with these words: that we recognise that the financial forecast will be revised following the board's decision not to delay elective treatment from NHSE providers. Does anyone want to comment on my suggested new bullet point? If not, then we move to the recommendation, and that's that we receive the financial report. We take assurance that the organisation has effective financial monitoring and reporting mechanisms in place. We recognise that given the current overspend and underlying trends, remedial actions with an impact of 9.4 million are necessary to achieve the financial plan, and we recognise that the financial forecast will be revised following the board's decision not to delay elective treatment for NHSE providers. Please indicate if you would like to either comment on your support of that recommendation or not to support it, as the case may be. So that too is supported unanimously. And we turn now to our integrated quality and performance report that Nicola is going to introduce. Thanks, Nick.
Thanks, Chair. This is the performance report for month 8, which is cumulatively up until November. Members will note that there are good achievements across half of the indicators, with improvement in others. Particularly acknowledging some of the update we heard and discussion we've had around vaccinations and our prevention measures. We do perform well when compared to the rest of the system on all of those, and just want to acknowledge the hard work of all of our teams in protecting our population in that way. In terms of some of the treatment measures, we have good performance in our provider services for the 104-week wait and the 52-week wait, therapies waiting times, and the experience that our patients have in our minor injuries units in terms of the waiting times there as well. I'm also really pleased to say that on the mental health measures for children and young people, we are compliant with all of those measures, which again will be a positive experience for our children and young people in terms of the way that service is measured. There are also areas in which we continue to improve, which have been challenged earlier in the year, notably diagnostics, with that improvement trajectory month on month. And that will continue on through the end of the year. Our provider arm cancer services are improving, although they are not yet where we need to be, and those the measurement against the pathway, still room for improvement in that. There is a mixed picture in terms of the mental health measures and that reporting. So very good in terms of interventions, an improving picture in terms of part 1A, which is around time to assessment, and really pleased to note that we've had that successful recruitment to 3 mental health practitioners to our team, which obviously, as we have small teams across Powys, is a big step forward. However, there is a decreasing compliance in terms of care and treatment planning, which is outlined in the paper, but also outlines that there's expected improvement from January 2025, bearing in mind this is the November report. Our neurodevelopmental services for children and young people remain in escalation. As at November, the trajectory in terms of RTT and so forth hadn't, that improvement wasn't seen then, but in terms of the escalation meetings, we are seeing that improvement, and that will be reported in future reports. Obviously, those are live and take place every fortnight. So in those live meetings that are reported through to the executive committee and thereby to the PECS committee, we'll be able to report that going forward. In commission services, we've had a lot of discussion today around the differential waiting times between the Welsh and the English systems, so I won't labour that in terms of this report, but it is evident in this report, as it has been in all reports throughout the year. In the Welsh system, we acknowledge that additional monies were released in the autumn, which hadn't quite shown that improvement in this report, bearing in mind, again, as I say, this is November, but our latest intelligence and confirmed by Welsh Government officials, as we expect 4 out of 6 of our provider health boards to meet the 104-week rate by the end of the year, with continuing improvement in the other 2. Cancer waiting times against the standards are challenging across the piece, and we continue to work with our providers through our performance management arrangements on that, particularly looking at the individual breaches and doing that analysis and working with them on those. And as I've reported in previous reports, the WAST response times remain challenging. There's no change in the services in escalation level 3, as reported in this report. And many of them are drawn, 3 of them being diagnostics, mental health part 1A, and neurodevelopmental services for children and young people I've already discussed. One of the others on delayed follow-ups is a data quality issue rather than actually a delivery issue. So I am doing a deep dive with the team to see where we are on that and to make sure that that is assessed and performance managed appropriately. And the other being colonoscopy, where again we benchmark well across the system, but for our patients are not where we want to be. So that's the summary of the performance integrated quality and performance report for month 8. Chair, and happy to take any comments or questions.
Thank you, Nicola. Please indicate if you'd like to come in and comment in response to the performance report. And I'll turn to Kirsty, please.
Thank you, Carl, and thank you, Nicola, for the report. As you say, ND services for children continue to be an area of concern, but as you also mentioned, we'll be picking that up in the PECS committee when it next meets. But I just do think we need to continue to ensure that the intervention is supporting that team to move forward. There are some positive things coming out of that work. Greater parental involvement and greater a parental voice in the development of those services. But whilst that is very, very welcome and not something that we've had in the past, if we're going to keep those parents engaged, then they're really going to want to see improvements to the actual delivery of the service. Can I say, though, it's also very welcome to see good performance in children's mental health. And I think, the neurodiversity services and our CAM services, need to, work together to make sure that children are in the right place and are receiving the right service. Which brings me to the new approach to a single front door for triaging our adult mental health. Which is a new and innovative way of approaching how we manage demand and hopefully bring improvements around mental health. But what we know from both locally and indeed nationally is the growing awareness that the first line treatment and in many cases second line treatment is around psychological therapy and psychological service. And I just wonder, given that there is a paucity of psychologists out there, and it's going to be very challenging to be able to meet demand by simply employing traditional job roles, what more can we do locally to upskill our staff who are currently working in our services to be able to, under the supervision of a psychologist, deliver psychological interventions, which hopefully will see us improve performance in that area, because increasingly the guidelines are going to tell us that should be the first line treatment for those individuals. So what can we do to increase capacity within our psychological services so that we can see improved performance? Thank you.
Thank you, Kirsty. You can see that Claire Roche as well wants to come in, Nicola, so you might want to bring Claire in, or should we go to Claire now and then come back to you?
Yes, that would be great. Thank you, Chair.
Okay, thank you, Claire.
Yeah, thank you, Chair. So, and Kirsty, thank you for, really pointing out the importance of children's ND services. And there will be a comprehensive report coming to the Patient Experience and Quality Committee in the next fortnight. But I do want to be able to give assurance to the board of the intense amount of work and focus that is happening in this area presently. And I suppose the first thing to say is that, we recognised that we needed as an organisation to place this service area into escalation to be able to increase our focus and have a really comprehensive improvements plan. I suppose just some key highlights, and they are just some highlights in the vast array of improvements that are currently underway. So we've recently recruited just over 3.5 full-time equivalent staff into that service who have commenced in post in the last couple of weeks. We have revised our clinic schedule to be able to increase the number of consultations we can undertake within a week. We last week undertook an extraordinary multidisciplinary review week where we had a real focus with our multidisciplinary team on reviewing those children who had been in the system with some extended waits, and over 90 children were reviewed as part of those reviews. We have been looking at joint appointments to be able to further support MDT working and discussions. Our procurement has concluded this week to be able to use some funding from Welsh Government to be able to scale up our assessments in the remaining part of this quarter by securing some external support for assessments. And we're also working as well to actually work towards far more short open pathways supported by caseload management process for clinicians. So I just want to give some assurance that there are a lot of very live improvements and actions happening presently, but we are also doing that with a lens of, and how do we need to transform this service to be able to future-proof it, not least because we know that demand has increased and demand is likely to continue increasing. So it isn't just about fixing some issues that we might have in our present processes, which is hugely important, but it's also about simultaneously looking at how we transfer these services for future proofing. And as the exec responsible for this service, I really welcome having the executive oversight every 2 weeks, because it is maintaining focus and a real drive in terms of taking forward our improvements. So just really felt it important that I do brief the board on the scale of work that is happening. Thank you.
Thank you, Claire. And I'm also going to invite Elaine to comment on the CAMS, Kirsty's observations around CAMS, and then perhaps Claire Madsen might like to come in on psychological therapies. Thank you, Elaine.
Yeah, thank you for the point, Kirsty. I think we're really happy, I suppose, with where we are with our CAMS performance relating to the mental health measure. I think comparing where we are across Wales, we're in a very strong position. And I think what's really critical is that we make sure that we continue and embed that. I think you made the comment about the triage an assessment process that we've got, and making sure that that works for all of our population, and that we can sustain that. So that's a relatively new service. It's one that we're looking now to recurrently embed and look at how that can have a much broader impact in terms of not just the immediate first port of call for our population, but then the next steps in terms of any additional assessment and care that they might need. That feeds into psychological therapies as well, and I won't tread on the sort of professional roles that Claire will come in about, but what we know is that we do have across all of our pathways in mental health We have a historical approach to prescribing whole packages of care, so 6, 8, 12 episodes in a course of treatment, and we know that there's a relatively small number of people who go through the totality of that, so we are sometimes losing capacity because we're still working within that previously prescribed approach. So what the triage and assessment process for children, young people, as well as for adults will allow us to do is to adjust and move from that. And we know that that's also part of the national approach to looking at how we can be more timely and responsive based on the needs that are presented to us on the day. So I hope that helps with that, and I'll pass over to Claire.
Thanks, Elaine, and thanks for the question, Kirsty. Claire Madsen, Executive Director of AHP's Health Sciences and Digital. Thank you for your question about psychology. I think we all acknowledge there's a huge challenge nationally to recruit psychologists, and it's really difficult. And just to assure, we are doing lots of work with HIW to look at how we're going to solve the problem in the future and looking at our future planning for training psychologists. So that's ongoing. And we have done work with the new CAPS roles and bringing psychologists in different levels into our organisation. We have a very active programme of recruiting psychology assistants within Powys to support psychologists. The challenge is all of these people bring in a lot of supervision requirements, and we actually need qualified psychologists to be supervising them. And the more of those sort of people we have, the less psychologists we have to actually do the work. So it's a bit of a balancing act that we're working with. We are, however, working with our psychologists to think laterally, to be creative with our skill mixing of the teams. We're looking at other opportunities. We're very much promoting 111 Press 2 for those people who need lower levels of psychological support and input, and the options that are available through that route. We're also actively signposting to other services. We have very active partners out in third sector and other areas where people can access support if that's the right level and the right intervention from them. So we actively signpost to our partners. And lastly, we have been doing a lot of demand and capacity work within our psychology teams to absolutely maximise our capacity, as Elaine was talking about, and also looking at modernising our performance. But Elaine's just reminded me to tell you our psychology performance is actually third in Wales. We aren't actually, in comparison with our colleagues, doing a bad job. So it's just challenging times, really.
Thank you. So Kirsty, would you like to comment on anything you've heard?
Yes, just to say thank you very much for the updates and the assurance. I acknowledge that we're third best in Wales, but we're not where we want to be. So being third best in Wales is little comfort to somebody that is waiting for that service. So I think we should be benchmarking ourselves against what we would believe an excellent service to be like, whether that's in the Welsh context or indeed the wider UK context. But thank you very much. I appreciate it's really challenging, and it's good to hear about the innovative ways in which we're trying to improve the capacity so that we can deliver those services. Thank you.
Thank you very much. So I can't see that anyone else wants to comment on this report, so we will move to the recommendation, which is that we discuss the content of the report. I think we can confidently say that that's happened, and that we take assurance that the Health Board has appropriate systems in place to monitor performance and respond to relevant issues. Does anybody want to comment on the recommendation or to indicate that they don't support the recommendation? So that too is supported unanimously. And before our lunch break, we come to item 4.3. Colleagues will remember our decision at the end of last calendar year, to implement temporary service changes, and also to our decision to monitor the implementation of those service changes carefully, and indeed to evaluate their effectiveness at this 6-month 6-month point. So we have on our agenda today an update report, and I'll ask our medical director, Kate, to present that to us. Thank you, Kate.
Thank you. Hello again, everybody. So I'm going to take the report as read, but bring out the important highlights, if that's okay. So the paper provides an update in relation to evaluation and monitoring of the temporary service changes, and updates on the mitigation plan, which is appended. So I think we're all aware of the changes, and just to confirm or repeat that the MIU changes were implemented in November, and that the co-location plans were implemented in early December. Just also to note that I've now taken on the chair of the Temporary Service Change Programme Board. So with regards to evaluation and monitoring, then to confirm that monitoring arrangements are in place with a group that meets monthly. The first meeting will be in February, and that will be reporting directly into the Temporary Service Change Programme Board. It'll monitor the progress and the evaluation, but also take assurance on mitigation. And I've said the plans for mitigation are appended to the paper. Can confirm that all the mitigations are on track. In addition, feedback is going to be, we committed to take feedback from key stakeholders. There are plans in place for that to take part at month 3 and month 6. Those surveys are complete and are ready to go. Just to update on any positive or negative impacts, we've discussed earlier in the conversation today that we have seen an improvement in flow and a reduction of out-of-county delays over the past 2 or 3 months. We have not done any formal evaluation yet. That will come at the end, and we are being cautious. We don't know the causes for that, but we do note that we have seen an improvement in flow in our system. There are no significant negative impacts to report. And just to confirm that, as we agreed, there'll be a full evaluation in June by the Evaluation and Monitoring Group and the Strategic Change Programme Board. Recommendations will then be taken to the Executive Committee and onto the board in July. So I will stop there and welcome any questions. Thank you.
Thank you. Colleagues, please come in if you'd like to. Simon.
Thank you, Chair. My question's around travel and transport, because I do recall at the time of the decision there was some concern around transport support. So I just wanted to check, it talks in the report about engagement with Powys County Council for continued focus on public transport routes between market towns. Just how has that progressed? Are we seeing any difficulties that we know of around transport? How and what was the outcome of engagement with the County Council? Thank you.
Thank you. So I might invite colleagues who are more directly involved in the co-location part of the work to come in on that. But the mitigation plan also comments that we have made arrangements such as flexible visiting times as well, and improved comms for patients in terms of tablets. So should visiting be difficult, it's easier to stay in touch with family and friends. But I think I might have seen Claire's hand go up and may be able to help in terms of the conversations on transport as well. Thanks, Claire.
Yes, Simon, so thank you. We have regular meetings to review the co-location implementation and any issues that are occurring. They have been weekly, and council members are invited to that meeting to hear any issues that are occurring. On conversation with the council, we understand that public transport is one of their main review issues that they're dealing with at the moment, as part of their reassessment of their funding, and so we are just feeding into that our concerns. So that's part of their decision-making process, and they're aware of all these areas. And to date, we haven't had any specific concerns raised to us about any individual patients or families.
Thank you. That's reassuring.
And Katie, I can see that you want to come in. Is it on the transport point or a different point?
No, Chair, it's on the wider point. We haven't received any complaints, is what I wanted to share with the board.
Well, please make your point, and then we move to Robert.
So I'm sorry, I was just going to say we haven't as yet received any complaints. We're keeping a close eye on it, and I've been in close contact with Kate and the board that's overseeing this, and just also inform board members that we will be undertaking some visits to the site. Well, we are in the early new year now, but later this month, the beginning of February, where we will be speaking to patients and ascertaining their views and understanding their experiences.
Yes, thank you, Kate. Robert, please come in.
Kate, are you able to confirm that when we do the review in June, that it will include an assessment of whether or not the changes to the MIU have resulted in a more stable service?
Yes, Robert, thank you for that. Absolutely. We were obviously concerned that we were having short notice overnight closures. To date, we've had no emergency closures since implementation. But we will formally evaluate that. It's early days.
Thank you very much. Just building on Katie's point, really important, isn't it, that we, as a board, meet and listen and learn. And I think, as I indicated in my report earlier on the agenda, Kirsty, the vice chair, and I also have it in our diaries to go and visit the Ready to Go Home wards and speak directly to staff and patients and so on, so that we have that additional source of assurance and information alongside the more formal data and information that will come to us in due course. So thank you. So there are no others that want to comment on this agenda item. The recommendation is that we receive the update on the progress to date, including the evaluation and monitoring plan, and that we take assurance in relation to the delivery of the mitigation plan. Again, any comments or anyone indicating they don't support the recommendation? So that also is supported unanimously. Thank you, colleagues. We're going to take our lunch break now. I'm going to suggest that we take 30 minutes or so. So can we reconvene, please, at 13:35? Just short of 30 minutes, but 13:35. Hopefully, I've got my maths and timings right. But I shall see you then, and bon appetit. Okay, can I assume that everyone is back with us? Liz or Helen, I don't know whether you can tell whether we're still waiting for anyone.
I think, Carl, from what I can see, we're good to go.
Marvellous. So welcome back one and all after our lunch break. We resume and we pick up our agenda at item 4.4, and that is our corporate risk register, and Helen, our Director of Corporate Governance, will introduce this item. Over to you, Helen.
Thanks very much, and good afternoon, everybody again. So I'm pleased to present to you what is now familiar report that the board see at every meeting on our corporate risk register. Just by means of a reminder, these are what are now the 12 strategic risks that carry strategic significance in terms of the delivery of our strategy. I say 12, we consider 3 of those in committee. They're designated as being more confidential. They're in relation to power outage, cybersecurity, and national IT programme development. So those 3 particular ones we will consider later, but the other 9 are fully available on the website and in the board pack. As you know, our corporate risk register is a significant element of our board assurance framework. And just to say that our committees, we've revised the role for our committees this year, and with the support of our committee chairs, all committees have continued to fulfil their full roles in reviewing these risks in more detail. Each committee has relevant risks apportioned to them according to the terms of reference and remit for those committees. Today, though, Carl, we are suggesting a change in one of the corporate risks. That's risk 001, and that's in relation to our financial forecast and savings in this current financial year, 2024-2025. And particularly on the back of some of the decisions that the board has made earlier today, we're recommending a change in the risk score for risk 1 from 16 to 20. So essentially it's an increase in the likelihood. That risk is at the ownership of the whole executive team, but Pete Hopgood is our senior risk owner, so we'll invite him to comment on it in a few moments if he wishes to. Other than that, the actions, the controls and the assurance levels have continued to be reviewed and updated. The assurance levels, we do continue to mature this. This is a new development in year, so we continue to find ways about working across all senior risk owners in the executive team to make sure that we're approaching those in a consistent way, and then as we continue to develop our level of assurance that we can offer to the board in that area. So, Carl, that's really all I was going to say on the report. Perhaps if you're happy, we can invite Pete to comment if there are any questions in relation to risk 1 specifically. Thank you.
Thank you, Helen. And I think given our discussions during this meeting already, that there will be a understanding and appreciation of why that risk scoring has increased. But colleagues, please indicate if you would like to comment on this report. Pete, also please come in if you have any additional observations to make. Chris, please.
Thank you, Chair, and thank you, Helen, for the report. I just wanted to pick up in relation to CRR 008.
Sorry, Chris. Sorry. Yeah, I think your mic was just a little, and there's something obscuring your camera. Yeah. Thank you.
Apologies. I was picking up on CRR 008. Microsoft have announced that they're no longer going to be supporting Windows 10 going forward, and I didn't know whether that increases issues regarding cyber attack, but it's whether we've got those systems robustly enough, and any merged or movement to Windows 11, does that impact on any clinical systems going forward with software applications, for example? And is there any increased cost liability of that decision?
Chris, can I suggest that you hold on to the question, given the particular sensitivities around that particular risk, as Helen has said, we will be looking at that in private in committee session immediately following this public session. So an important question, but can I ask that we deal with it there rather than here?
Sure, fine.
Thank you.
Thank you.
Thank you. I can't see that anyone else wants to come in, and neither can I see that Pete has any additional comment to make. And so, unless there's anything else from you, Helen, we'll go to the recommendation.
Nothing else from me, Carl. Thank you. I think this is an item we look at very regularly and in some detail in the committees. So thank you.
So we're asked to review the corporate risk register as it's been updated. That's included at Appendix 1, ensuring that it's a complete and true reflection of the Health Board's current high-level risks. We're also asked to support the increased risk score of CRR 001 in relation to financial forecast, which is increased from a scoring of 16 to 20, and that's a recommendation from our executive committee. And we take assurance on the controls and assurance to manage strategic risks, and there are actions to address any identified gaps. Please indicate anyone that would like to comment on that recommendation or to indicate that you don't support it. Thank you. That too is supported. And we go now to consider a report against our digital strategic framework. This was adopted last year by us as a board. And so I think it's the first time that we've had a performance report, as it were, against this framework. So that's really, really welcome. And Claire Madsen will introduce it. And also, Claire, you'll invite Vicky as well to come in and speak to some of the detail. Thank you.
Thank you, Chair. So yes, this is our first digital strategic framework annual report, which reports on our monitoring criteria and just gives you a generalised update up against where we are against our plan, and also just highlights some of the areas where we're doing really well and also some of the challenges that we have coming up in the future. So I'd just like to we'll assure you, we'll assume you've read the report, and I'd like to ask Vicky to just highlight a couple of areas to you, please.
Welcome, Vicky. Please come in.
Thank you. Hi, everybody. I'm Vicky Cooper. I'm the Chief Digital and Data Officer for Powys Teaching Health Board. It's quite exciting for us to have achieved this first annual performance report. Our strategic framework was approved in 2023. So what I've gone, I'm not going to go into too much detail because I'm sure you've read the report, but I've just put together 4 slides, which is a SWOT analysis on reflection of the first year. So I'll just briefly go through each of those without reading every one as it is. So strengths, starting with our strengths, we're quite pleased that as part of our plan, we knew we had to invest and improve our aged and legacy digital infrastructure and network connectivity. We had a lot of outages at the time, up until about last year. So with that investment and improvement, we've reduced incidents, faults, and the downtime. We've developed a cloud-first data platform, which will be our single source of the truth for business decisions. It has AI built-in capability. So once all our data sets are migrated, we are still in transition. That will be quite a powerful platform for us to use, and we can connect third-party data sets to that as well. So we can include other providers, primary care, social, voluntary sector, etc. We've also aligned our clinical informatics team. This is quite an important alignment, structural alignment, making the clinical colleagues really integral to our digital services and our overall strategy. So we can evidence now and safely say we're clinically led, patient-centred as part of our digital service offering, and that'll help us join up digital across the organisation. Next slide, please, for weaknesses. Thank you. So the first one is the cross-border programme, which has had challenges and delays to sharing patient information across the regions. We do now have actions and increased capacity to in place to meet the revised timeline, which is March 2025, with the exception of pathology results, which will be delivered by May 2025. But it is acknowledged that this is much wider than Powys. There are there's national policies that need to be reviewed by Welsh Government and Digital Health and Care Wales. There's financing targets that are impacted, so it's not just about information flow, it's much wider. We also recognise that there are gaps in our digital confidence in the health board and our training, and as such this slows down adoption of some of our digital solutions. And we aim to bridge the gap with these by introducing a recognised training function that will provide regular sessions, workshops, e-learning modules, as well as ongoing and regular support to get the best out of our systems. In terms of commissioning services, so as a community provider, as you'll know, we commission services, but this introduces variation in digital and pathways, in particular the administration of those pathways. So we're picking this up as part of the transformation programme work streams to look at how we can streamline and standardise those processes across all pathways. And then finally, as touched on in the previous agenda item, we do have a corporate risk logged around national and local digital programmes. So it introduces conflicting priorities, which creates resource constraints. So we're actively monitoring that through the corporate risk register. Next slide, please, for opportunities. So opportunities, we've done a digital demand and capacity review. So we have our business as usual, we have our IMTPs, we have our strategic framework to deliver. We've also got to consider the wider digital resource needs across all services. There's a growing demand for digital and skills, as I know you'll appreciate. So we're looking at how we can work together to meet the current and future demands. And this kind of links in with our planning and prioritisation. So we're looking at how we prioritise our workload and how that might be clinically led. Are we looking at financial, clinical, safety, risk, etc. in the way that we prioritise our workload? And then the final slide, please, which is threats. So we have, just touching back on the growing demand for digital services and skills, recognising the increased need. We need to enable the transformation and ensure that's a success. We're very much aligned to the business efficiencies programme, but this is all about improving our patient outcomes and recognising the power that digital has to enable the transformation. Also, we have a threat of short-term funding models for some of the national programmes. So there is a need to advocate for a more sustainable long-term funding position for stable and skilled resource base to deliver the business change and these quite complex programmes that we have in the pipeline. Our national clinical applications are often quite secondary care focused. We know they don't fit the needs of Powys, a community and primary care aligned organisation. So that's again something that we're raising regularly at every opportunity so that we can ensure that community pathways are well understood. And the ever evolving cyber threat that we have, so we must remain vigilant in our measures to ensure we're resilient as possible, conduct regular audits, train staff and invest in our advanced technologies. So I will pause there. Thank you very much, and take any feedback or questions.
Many thanks, Vicky. And as I said earlier, really, really good to have this report. Marvellous to see the progress that's been made, and certainly it feels and it seems to me to be in a much more cohesive, coordinated and integrated place than you know we've had in the past. So big thank you to you and your colleagues. And just before I turn to board members for contributions, again, just a little reminder that we will have opportunity in our in-private meeting to discuss some of the risks that Vicky has highlighted in this report. So any conversation about those particular risks we will deal with then. But let's go firstly to Robert.
Oh, if Ian Phillips was here today, he'd be very pleased with the grip, as he would say. And I'm actually having lunch with him on Friday, so I will update him. But thank you very much for that. And it's as well as the report itself, it's also about us having confidence in the monitoring going forward. No, I'm not sure, Carl, whether this falls into the category you mentioned, whether we should defer the discussion of this, but there is a section in the key challenges on the cross-border programme. So would that fall into the category that we would discuss it later? No.
No, I think that's appropriate for now,
okay.
Robert, absolutely.
Because it's quite unusually explicit, really, I think. So we've got here that cross-border collaboration has reached a critical point, that the impact on operations unacceptable, escalation. So I'd like to know really where we are on that, because presumably the escalation has started and might have to have an observation from Claire and also from Hayley. And then I'd like to ask, are there similar concerns over the aspects, similar aspects for the Welsh app? Thank you very much.
Shall I come in, Carl? So we did reach a stage where we weren't achieving the outcomes that we'd set ourselves with regarding to cross-border, and we were concerned that we wouldn't meet any of the requirements. However, we have escalated this issue, and we've had a really good outcome from this escalation, in that, as Vicky said earlier, we are on target to deliver most of the cross-border work by March 25. We've got one area which is not going to deliver on time, but we've got an agreement now that that will be delivered within a couple of months after the target date. So we are confident now that we will have delivered all of our outcomes that we'd set ourselves, with a little bit of a delay. So a really good outcome from the escalation. I don't know if you want to add anything, Vicky.
The Welsh app. The Welsh app.
I don't know where we are with the Welsh app. That's being centrally led. There is a big meeting coming up in the next month that is happening in 3 different bases across Wales, really looking at where we're at, what we need to do next, and the targets to be set. So we will be attending those meetings and participating in the rollout of the app.
Because there is a cross-border aspect to the app, isn't there? Yeah, thank you. Thank you, Chair.
Thank you, Robert. Steve.
Thanks, Vicky. You mentioned that short-term funding is one of the key threats to the programme. In that context, in regard of benefits that are anticipated in, when digital investment is put in place, is there a process for tracking delivery of those benefits and ensuring that where there was an intention to make savings that would help fund the ongoing investment, that process is in place? Thanks.
Thank you. Shall I come back in?
Yes, please do, Vicky.
Yes, so there is we have a local benefits efficiency framework. It's quite new that we need to embed throughout our programme implementation. And there's also been a nationally designed benefits efficiency framework, because I think this is recognised across all health boards. And again, it's when you don't have quite the sustainable team seeing this through to post implementation and gathering those benefits, that's where we've been quite weak. So we now have the framework in place, we have our templates, we know what we have to do. We've got to go through the phase now of actually implementing that and ensuring that we understand who our benefits owners are and how we feed that back through the organisation.
Stephen, if I come in here, we've it's been a system whereby with IT implementation or digital implementation that the implementation funding dates program seemed to end when we implemented. And so what we've done with our new programming plan is we've built in another 6 months into our programming plans to make sure we're building evaluation and really robustly going forwards. So we've changed all of our templates for our program teams to ensure that we put that in place now.
Thank you.
Okay, thank you, Steve. And Kathy.
Hi, yeah, Kathy Poynton, independent member. You're right, Vicky. You mentioned the need for more digital experience and expertise. Are we investing in the staff we have to take them along with us and give them the expertise? And are we linking in with the colleges or whoever to grow your own, so to speak? Because we know digital technology is in high demand, and therefore the people who can do it will be in high demand.
Shall I come in first on that one, Kathy? So I think if we start with our new graduates, that they're technically more advanced than most of us, we're finding. So they come out with very high expectations to use digital means anyway, and they tend to be very skilled. They're also being taught on very good high technology machines and various things in their undergraduate places. So they come out very well trained. We just have to give them the right appropriate training. I think there is a real challenge for us to take the rest of our staff with us, and Vicky's team and other teams have been engaging with local organisations who will empower and train people in technology, and we've made those courses accessible to our staff. I think that was one of our reasons to bring the clinical digital team into the digital team. So we were always thinking about how we embed these changes from day one with a clinical viewpoint around the table with us. So we are certainly doing that going forwards. But I think you're absolutely right. Uptake and delivery is the key thing to make this successful. So we have to work with our staff all the time. I don't know if you want to add anything on that, Vicky.
Yeah, thanks. And I think having the clinical informatics team means that staff are more comfortable in sharing their fears, their competency with their own team than they are in telling us in digital. So another benefit of having the clinical informatics team is that we can now start to have some of those structured conversations. We can get that insight back and we can formulate a kind of a plan of how we're going to address it. And one starts tomorrow, actually, in Spa Road with the district nurses. So we're having a day, we're phasing it. So day one is technical, using the equipment, etc. And day two, which will be further scheduled, will be on the applications. So not to overload, but just to have that very sort of informal conversation, two-way, how do I do this? And am I doing this right sort of conversation? So we're really looking forward to those.
Thank you. I can see that Kate wants to contribute as well. If it's on this point, Kate, then please come in.
Yeah, thank you. It is related, I think, and it's a comment really rather than a question. And I think it's probably stating the obvious, but it's really important, and it's highlighted in the paper. But just more than ever, with the work that we're doing to join our teams and improve our systems and improve our efficiency of clinical working, then the interoperability of our clinical systems is more important than ever. I know that Claire and Vicky and everybody else fully understand this, and I'm stating the obvious, but I think it's really, really important and remains challenging for us given our complexity.
Thank you. So we go now to Kirsty.
Thank you, Carl, and thank you to Vicky for the paper. And forgive me if this is something I've missed or whether this is a stupid question, but Obviously, the connectivity between the Welsh system and the English system has been very much in the news since the Welsh Affairs Committee and the evidence that was given to the Welsh Affairs Committee last week. But I'm just wondering, Vicky, is it as simple as just Wales's system doesn't speak to the English system, or but because we've got multiple providers in the English system, actually we're trying to find solutions across multiple providers? So is it the case that there is simply one system in England that we have to connect to, or actually is there a South system, is there a Wye Valley system, are there multiple systems? Because the impression was kind of given in that hearing that there's a Welsh way and then there's the English way, and if we just adopted one way that would be much better, but my understanding was it's much more complex than that.
Yeah, it is more complex than that, and they don't all sit on the same system in England. However, they work to different standards as well, and they use different coding. So so you have the English versus Wales, Wales versus English set of standards, but the English providers will, whilst they might be on different systems, they work to the same set of standards. We're not quite there yet. In Wales, so we couldn't hand on heart say we are in that same position, but I think they have opened up the English systems now to be able to have that information flow, and we need to make sure that our architecture allows us to plug in and them to plug into us in the same safe and secure way that they're doing it individually as trusts in England.
Thank you, that's really helpful. That's clarified exactly how it works. Thank you, Vicky.
Thank you, and thank you all. And right at the beginning of this meeting, I explained that one of our main responsibilities as a board is to set strategic direction. And I think in the paper, Vicky, it's really assuring to see how that strategic alignment is happening as well. We've acknowledged that at our March meeting, and indeed at future meetings, we will be considering our plan for next year and for future years. And so, the alignment of our clinical strategy, of our estate strategy, of our digital strategy, both in our annual plans, but also in that better together direction is crucial. And I think the assurance that you've given us in this paper that that certainly is something that's happening. I'm sure there's more work to do, but there's something that's happening is really good to receive. So thank you. So we are asked then to take assurance that arrangements that are in place for continued delivery against the digital strategic framework, to consider the updates in the annual report in relation to the first 12 months of delivery, to take assurance of the actions and work streams undertaken to improve and upgrade the digital services offering as set out in the DSF, to note the key achievements and successful implementation of the target operating model following the Section 33 TUPE arrangements, and to note the structure alignment of clinical informatics to the digital directorate. I'll pause once again for comments, or for should anyone want to indicate that they don't support the recommendation. That is supported with gratitude. Thank you. We come now to item 4.6 and to the paper on nurse staffing levels, and we go back to Claire Roche. Thank you, Claire.
Diolch, thank you, Chair. So this is the annual report that is required under the Nurse Staffing Act. Really important, I think, Chair, just to draw to the board's attention. This is normally a report that is brought to the board around September time. That has been delayed on this occasion due to a number of unforeseen circumstances. So just wanted to note that and apologise to the board that it is coming slightly late in this year. So the Nurse Staffing Act 2016 places a duty on all health boards to ensure that sufficient nurses are required to enable nurses to care for patients sensitively. The Act consists of 5 sections, and our community wards in PTHB fall under Section 25A. As the designated person for the Health Board, I assess nurse staffing levels and agree the required level of both registered nurses and healthcare support workers to be rostered on each shift. The annual ward establishment reviews take place, and you will note from the report that going forward, our model for undertaking these will be reviewed and matured in 25-26. Section 25 of the Act also places a duty on the Health Board to have robust workforce plans to both recruit and retain nurses. And you will note on page 5 of the report a high-level summary of the work programmes and actions that support this. I would like to draw out of that list our overseas recruitment of internationally educated nurses. And since 2022 to date, we have recruited and placed 25 internationally educated nurses across our community hospitals across the county. In the spring of this year, we will also have 6 internationally educated nurses who will join us, and these will be allocated to our wards at Brecon. This focused work to recruit overseas nurses is having a positive impact on our registered nurse vacancy rates. And I would like to take this opportunity to not only thank those internationally educated nurses who have joined us and settled into our service so seamlessly, but I would also like to take the opportunity to thank our teams across the Health Board that have welcomed those colleagues and have really enabled them to settle into Wales. In terms of our commission services, it's really important to note that in Wales, the health boards that we commission services from are subject to Section 25B of the Act, and nurse staffing levels in those areas are reviewed every 6 months. All health boards publish an annual report, and we receive these reports as a commissioner. In England, there is no law related to nurse staffing. However, our commissioning agreement includes the requirement of receiving assurance of nurse staffing level, and through our commissioning team and our quality and safety team attend our contract quality performance and review meetings, of which nurse staffing is a key component. I'll pause there, Chair, and happy to take any questions.
Much appreciated, Claire. Thank you so much. I'm going to go, I think we've got some connection issues with Ian Thomas, and so he has sent through a question or that he would like me to put on his behalf. So, I will read what Ian has sent to me. Overall, a good report that gives good assurance and demonstrates compliance. Maintenance of nurse staffing levels is crucial, and I wanted to better understand how we are progressing. Recruitment of a workforce retention lead to support the recruitment and retention of staff, aligning outcomes with the nurse retention plan set out by HEIW. Any response to that, Claire?
So clearly we do have a member of staff now that is focusing on recruitment and retention. I think it's really important to say, and I'm sure Deb may want to come in on this as well, that that is not specific to nursing. That person has been appointed to look at all of our professional groups in terms of recruitment and retention. But of course, we do have the published nurse retention plan. So nursing has been a particular initial focus for that member of staff. I think it's also important to say that recruitment and retention needs to have multiple actions under one broad objective. So while I've drawn out there the really positive progress and story that we've had with our internationally educated nurses, that is in effect one swim lane to get us to sustainable nurse staffing. Our Aspiring Nurse programme is another key objective. And of course, the work we're doing to retain our staff in terms of developing our staff, the work that is being done around staff welfare and staff wellbeing, which Deb referenced earlier, all of these things are really important parts of the jigsaw puzzle. It's not about one action being able to meet the objective. So I'll just pause there. I'm not sure if Deb wanted to come in as well.
I did see that Deb, oh yes, Deb does want to comment. Please do.
Thanks for that. I agree with everything that Claire just said. You know, we've been discussing, and I think I might have referred to recruitment as kind of running a bath with the plug out, because retention is the other essential element. There is a national lead within health Education Improvement Wales, HEIW, and they allocated funding to all health boards to recruit a local lead. Ours has been in place for about 6 months with an extensive plan, not just around nursing, as Claire has said, but across other professional groups. And whilst it's early days and there is still a lot of the plan to work through, I can report that against our previous position as being an outlier in Wales in terms of our turnover rates, we've seen a 3% reduction in the last 6 months. So clearly something is working, and I think the attention and the conversations and the importance of the relationship between line manager contact and staff is really important. It was a subject of a bit of a deep dive into workforce and culture, and will continue to be on that agenda just to review the development and the implementation of the plan and see the progress that's being made. I hope that answers Ian's question. Thanks.
Thank you, Deb. Ian, I'm really sorry that you're not able to contribute in the usual way. If you do have any supplementary questions or observations, then, and if you can get some kind of chat message to me, I'm very happy to put those on your behalf. But in the meantime, let's go to Mick.
Thanks, Chair. Hi, Claire. Claire, just two questions if I may. The first was a kind of wider question, and it might be my lack of understanding the purpose of the paper, so I apologise. But it clearly provides assurance that we have arrangements in place to ensure we comply with the Act, but it doesn't tell us much about compliance with the levels that we've set and how that translates into quality and safety for service users. So I just wondered if there was a different mechanism for monitoring those issues. And the second question was just a question of detail on page 459 of the board book, which is page 4 of your paper. It talks about compliance levels for data capture, and it describes a range from 61 to 98%, which seems to be quite a significant variation. I wondered, you know, do we understand the reasons for that, and what does that mean in terms of the data quality, and you know, what are we doing to make that more consistent?
Yeah, thank you, Mick. So I suppose I do acknowledge that this is a paper that is providing assurance to the board of the arrangements that are in place to be able to monitor compliance with staffing levels. I haven't in the paper gone into details of operationally how we monitor those staffing levels, and in particular how we obviously triangulate data in terms of incidents or concerns. And that is going to be a really particular key focus going into 25-26. You'll notice in the paper that I reference that we're going to mature our approach to monitoring nurse staffing levels, to be able to really meet with the ward managers, to be able to understand that actually they themselves are triangulating their incident data, their concerns or complaints data, along with tracking their staffing data. As in terms of incident management, we do review any incidents that occur within an inpatient ward to be able to look at if there is any correlation with a reduction in nurse staffing. But I haven't in this paper drawn that out, Mick. This is more of a high-level paper to board to provide assurance of the arrangements in place with how we monitor nurse staffing levels throughout the organisation, as opposed to detailed data underneath that. In relation to what you reference on page 4 around the data in relation to safe care. We are monitoring our data in safe care. We haven't actually had safe care within the organisation for a long period of time. There are still some nuances with that data, and we are continuing to be able to work on that. So I think at the moment what we're saying is that we have got some variation in relation to the data being reported, but we are working with our operational teams to be able to strengthen those local arrangements so that actually we've got much more consistency across all of our wards.
So sorry, Claire. So just so I'm clear, so the kind of system that for monitoring compliance against the the framework that's set, that's in development, and presumably does that go through to PACS at some stage, or is it an operational performance issue?
So I take any paper in relation to nurse staffing comes through to the executive committee. So once I've reviewed the establishments, and once I've effectively, what I do is I review the numbers of registered nurses and healthcare support workers that are required on a shift on a community ward. And because of the fact that our community wards have different numbers of beds, they have very different environments of care, they have although broadly they tend to have the same demographic of patients, there may also be specific site arrangements that are really important to address. So actually undertaking establishment reviews in a community setting is probably far more nuanced than understanding an establishment and roster review in a district general hospital, where you've effectively got similar numbers of beds on very similar wards with very similar environments of care, along a corridor in a big district general hospital. So our establishment reviews are far more about being able to not just look at number of beds or patient demographics, but also looking at the environment of care and the site responsibilities. Some of our wards are quite isolated, and particularly out of hours, they may be the only department in a site that is operating. So there will be site responsibilities for those nurses in addition to ward responsibilities. So we consider the out of hours medical cover, we consider lone working issues. So all of that is quite complex in terms of being able to set those rosters. Once I've agreed what I believe is a professionally sensible and reasonable level of registered nurses and healthcare support workers, I submit that and report it through to the executive committee, and that then forms the basis of our agreed staffing levels over a period of time. And that's why it's really important to do it annually, because things will change. So, for example, one of our wards has had slightly less beds over this year. And if we think about the example of the ready to go home units, where we have a different demographic of patients, then those roster levels were revised and amended in light of that change.
Okay, thanks. So probably not the right place for the conversation, but it feels to me like safe staffing levels are a critical component of a safe and effective, high quality service. And I just have a sense that that's something that somewhere the board should have some sort of oversight of. But I accept this is not a place for that conversation. Thanks for the clarity, Claire.
Thank you, Mick, and thank you, Claire. And perhaps we could just capture Mick's observation, and Helen, just looking to you, we can consider how cited we are as a board through our committee structures and so on the issues that that Mick raises, and whether or not we need to make some tweaks or changes in terms of our monitoring of those matters.
Very happy to do that, Carl. We'll take it as an action, and we'll work with Claire and other colleagues on that as well.
Thank you. And so we have Ronnie and Chris that want to come in. So I'll take both one after the other, and then we will move to the recommendations. Thank you, Ronnie.
Thank you, Carl. Claire, I think this is a good report. I have a number of observations around it. I think you said there were 25 internationally qualified nurses now working here. Is that correct?
Yep, that is correct, with the further 6 coming in the spring.
Okay, so on the basis that Pete has told me previously that the appointment of full-time nurse saves about £50,000 in agency costs, if you multiply that up, that's a considerable cost saving to the health board. By my calculation, it's £1.25 million. So that's substantial. Claire, I don't know anything about internationally qualified nurses. I know a little bit about international medical graduates, which is not the same thing at all, and I know that. But what I want to say is that IMGs generally have a bit more trouble passing their exams, and they have a bit more trouble settling down because they come from a different culture. And I know that you've said that HEIW have provided funding to put a support mechanism around them. So I just wanted to be certain that we were doing everything we could to make them feel at home and to make them feel encouraged. And also just to get a sense of where they stand in relation to their OSCEs. Do they get through them first time? Are there many examples of resits? I'm just interested to know the dynamics of how all of that fits. Thank you, Claire.
Thank you. So we'll hold on to Ronnie's comment and question, Claire, if we can, please, before, and we'll invite Chris to make his contribution.
Helps if I come off mute. Not on there. Thank you, Claire, and thank you for the report. I think it does help, but obviously when these reports come out, they generate some questions and that on there. But thank you for the report on there. On page 2 of the report, you give the various sections of the Act, which is fine. And you're saying that for the majority of our wards, 25A applies across the board. On page 3, at the top, there is a paragraph that highlights that, but then it says, although the health board is not required to do section 25B duties, the overarching principles and guidance are followed with Powys Teaching Health Board. If I then look at section 25B, there is a statement there saying that the health board is also required to inform patients of nurse staffing levels. Do we do that, and how is that done? I'm just trying to envisage how that is done. Do we have a board up saying how many people are on duty? The names given? How is that happening?
So Claire, thank you. So if we take Ronnie and Chris's observations and questions together, please.
Yeah, thank you. Really helpful questions. So, Ronnie, in relation to our internationally educated nurses that have come over from Kerala in India, I suppose the first thing I want to say is that in the last few years, when we have worked with Welsh Government and HEIW to do this all Wales recruitment, we have made sure that a Powys representation has gone on that delegation. So we have not relied on other people to recruit our nurses for us. And I think that's been really important, because when we have sent one of our own nurses, and that might be a nurse on one occasion from the operational teams, and the next year it will be from a corporate team, then actually we're sending somebody who really knows and understands Powys Teaching Health Board, knows and understands the county of Powys and the rurality of Powys and the culture of our communities. So we have been able to be really focused in targeting our recruitment and trying to recruit people who want to work in a community setting, in a rural setting, and where they're able to ask whoever's gone out there to recruit really targeted questions about what Powys is like. And I think that that has been really important, because what we have seen is the nurses that have come to work in Powys over the last 2 years have remained in Powys. We have had a real success rate with them coming into the county, settling into the county, settling into the community and remaining. So I think that is a key component of our recruitment. In terms of our OXIs, we actually have a really good success rate. And I think we've learned quite a lot as an organisation in 2 years. So whereas initially our couple of cohorts, we would see that maybe 1 or 2 of our nurses would need to resit their OXIs on one occasion. In our last cohort that came across, all 6 of them passed their OXIs first time. So I think that is a combination of us learning how best to support them, and that continual learning has enabled the success. I referred a little bit to the, the really amazing response of our local teams to really embrace their colleagues, really support them to integrate into the community. But we've also look to do some other things to help them settle, not just into the Powys community, but the UK community. And we recognise that the culture of healthcare in Kerala is very different to the culture of healthcare in the UK. So one of the things that we've done is we've engaged with the British Indian Nurses Association, known as BINA, and their sole purpose is to help and enable Indian nurses settle into UK culture, and also be able to help and support them to develop their careers, which is really important. We don't just want our nurses from overseas to be coming and to be filling our vacancies. We want them to have really successful careers. We want to see them transitioning into leadership roles. So one of our nurses from Llandrindod Wells is our Powys representation at the BINA Association, and essentially is sort of a link between BINA, our Indian nurses in Powys, and then the corporate nursing team in terms of maximising opportunities where they can access support and share learning with other colleagues in other organisations. Chris, in relation to, sorry, you're going to have to repeat your question because I was trying to write it down and remember it all. Sorry. You're on mute.
You're on
Apologies.
mute, Chris.
Apologies. My question was in relation to
about the Act.
Section 25B, it mentions on there that health boards will also be required to inform patients of the nurse staffing levels. Are we applying that if you're taking the general principles of it, or are we not? And if you could just then explain why that principle doesn't apply to us in that same regard. There are other questions, Claire, but I'll send you an email for you to respond to them as well.
Yeah, thank you. So basically what I'm trying to say in the paper is that if you take the Act quite literally, the organisations are only expected to report formally on 25B wards. And the triangulation method for assessing nurse staffing does specifically relate to 25B. In the absence of having any methodology for 25A wards, and I have raised this at a national level, then me and my team adopt the triangulation methodology and apply it to 25A wards in the same way. In terms of informing the public, then certainly the expectation is that our staffing levels are not a secret. I think we could probably do much better at publicising those agreed staffing levels on a board within our ward. And it has been a subject of conversation in how we develop our how are we doing boards. But I think I would recognise that we probably need to do a little bit more work in that area in terms of transparency.
Okay, that's helpful. Thank you.
Thank you very much indeed, and thank you, Claire, for the report and for the way in which you've engaged very openly and very helpfully with the questions. And so we go to the recommendation, which is to receive the report, to take assurance that the Health Board meets its statutory requirements under section 25A of the Act, and also to note the arrangements in place to ensure that our Health Board is meeting its requirement to consider outcomes for Powys patients receiving care from other providers which may be affected by nurse staffing levels in commissioned services. And so once again, please indicate if you want to comment or if you don't support the recommendation. That is supported. Thank you. So we come now to the report of our Regional Director of Powys, Katie, and over to you. Thank you.
Diolch, Carl. The paper is actually in the bundle of papers. It says on the agenda it's a verbal update, but I submitted my report a little late. So the paper is actually there for board members to read. And what I've done is just to share some infographics, and also there's a link there to a video. I think we've talked before, I've mentioned before that we're trying to move away from sort of lengthy reports of what we've done and trying to make things a little bit more interesting and animated. So please feel free to have a look at those in your spare time if you haven't had an opportunity to yet. Just before Christmas, we held a public forum in Crickhowell, which was really, really well attended, and there were representatives from the Health Board and the local authority, and a couple of councillors were there. And we had about 40 members of the public that were there. It was a roundtable discussion, and I will share with you when we finalise the report some of the outcomes. But we asked individuals for their top 3 priorities for health and their top 3 priorities for social care, because quite often it's sort of health and social care. So it was actually about making sure that we could distinguish between what people felt. So there was quite a lot of interesting things that came out of that, but also some useful sort of suggestions as to what would make a difference as well. I just want to pick up from something that Chris said earlier about stroke. I think it was in Hayley's report. We keep hearing and continuing to hear concerns from members of the public about accessing stroke services, and about how stroke services appear to be moving away from Powys, whether that's down to the Royal Glamorgan, whether that's potentially to Worcester, whether, depending on the changes that are being discussed with Hywel Dda, there may be changes there. So it's something that I'm raising and continue to raise at a national level within Llais, about the need for a coordinated understanding of what the different pathways are and what the impact on some of these changes are. So just to provide a bit of assurance on that from our perspective. And then finally, we're currently going through our planning process for 25-26. There'll be a few changes to the way that we operate, but we're going to continue to focus on Llais Local, where we go in for a dedicated period of time, usually 2 weeks, to listen to the community, because that seems to be working really, really well in Powys. So once I've got those, and once that's sort of been finalised, we'll obviously share that with everybody. I think finally, the other thing just to say, just whilst the meeting has taken place, I've just looked at our schedule for the next quarter, and we're looking at visiting the Ready to Go Home units in the middle of March. So wanted to give them time just to sort of settle in and for people to sort of get into the the routine and the process. So we're visiting in the middle of March. So we'll make sure that we're not all there on the same day. I'll check that out. But I think that's all from me for now. It's been a fairly quiet period over Christmas, and I think what I've shared in the report, I hope clearly shows the activity.
As always, Katie, thank you so much, and for the way in which the information is presented, and certainly if we haven't yet had opportunity to watch the videos, then I'm sure we will. But Hayley, please come in.
Yeah, thank you, Katie. And just a couple of comments, just listening to the points that you raised about the public's concerns around stroke services, but also you were drawing some of the examples around the changes around our border as a county impacts not just within Wales but also cross-border into England. I think the discussion in the next Planning, Partnership and Public Health Committee is really critical, because there are two papers, the Strategic Change Report, which gives you a summary of all of this work, but also that deep dive into stroke is an important one, because I think for us in Powys, we need to make sense of what the overall map of stroke provision looks like, because of the very complex pathways our patients go on. So really look forward to working with you on that. I just noted in your report, Katie, the activity under advocacy that you lead, particularly number of new cases, number of closed cases, and also the number of open cases. And I know that you share more detail, but I think how we triangulate that information is really important to understand thematically if there are particular issues that are arising or hotspots, as I describe it, from your work, and how that fits with the Civica system and the concerns and complaints analysis that we do locally. So I know that work is in train, but just getting a bit of a sense of, are there any sort of key themes you wanted to draw our attention to from the work over the last period? Thanks.
Can I just come back on that, Carl? Is that okay? I think, Hayley, just to provide you as Chief Exec with reassurance and assurance, if we do pick up themes, and we do sometimes pick up themes, you know, let's be honest, there sometimes are patterns with a particular area or a particular service, we will go directly to your executive colleagues for discussions. And, you know, I can think of a number of examples which I don't think would be appropriate for me to shed here, but I can think of a number of examples where we've had conversations and actually the executive team have acted upon the concerns that we've perhaps raised. So just, you know, I'm a bit hesitant in sort of going into too many specifics in a report, but just to provide you with that assurance that behind the scenes, we have very strong relationships with each and every one of your exec colleagues.
Thank you very much indeed. I'll just pause if there are any others that would like to come in conversation with Katie. Nope. So once again, Katie, many thanks, and thanks for your, not just this, but your contribution to our meeting today more generally. Thank you. We receive Katie's Llais report, and we turn now to item 5 on our agenda, which is the consent agenda. And as I explained earlier, the items within this part of the agenda are taken en bloc, not for further discussion. And unless anyone indicates to the contrary, I'll assume that everyone approves the recommendations against each of those consent agenda items. Thank you. I haven't been made aware of any other business, so I assume that there isn't any. The date of our next meeting is the 26th of March 2025. Colleagues, we are due to meet in an in-committee session. We were due to start at 14:30. This meeting has taken a little longer than we had planned, so I'm going to suggest that we still take a 10-minute break before we meet in the in-committee meeting, and so we'll start that meeting at 14:50, so 10 to 3. But it just remains for me to say a big thank you once again to everyone that has prepared for this meeting and helped it to run so smoothly, to everyone that's contributed to it, both in presenting information and in taking part in questions, discussions and conversations on that information, and indeed participating in the decisions that we've made today. Diolch i chi gyd am eich cyfraniadau ac am y trafodaeth dyn ni wedi cael ar penderfyniadau dyn ni wedi cymryd heddiw. Diolch o galon. And that concludes our business, and so I close the meeting for today. Thank you.